So we are going to do a practice one, it sounds like. Oh, yeah. Oh, that's
Good afternoon. So we're going to resume our meeting, and prior to moving into the CEPAC deliberation and voting, I'd like to ask if there are any additional thoughts or comments from members of our panel regarding the clinical evidence. Please feel free.
Is this?
Yeah.
Okay. A couple of comments, mostly to do with the first presentation on the summary. One is there was some discussion about the reliability of aims in terms of measuring impact. And there was a discussion about, for instance, that if you had facial movements and no other area, that may have a disproportionate impact on your life. It goes beyond that, I think, because it not only goes into terms of social impact and the way that other people react to you, but it also, you may have a relatively small amount of movement in your hands, and yet if your job is that you're a writer or you're typing, it has a tremendous effect on your ability to work in life. And that goes throughout the types of impact it can have on you. The other point that I wanted to make, too, was we were talking about that there may be this additional effect of having these new medications possible that may have people be more adherent to taking their medications for their primary condition. We did a series of focus groups around the country with people living with TD, and we had a lot of really interesting outcomes, but one that we didn't expect, and we had it in multiple groups, was individuals saying that they were reluctant or even refused to tell their primary psychiatrist about their TD symptoms because they were afraid that they would be taken off their primary medication or that it would be reduced, and that it had such a positive effect on their life they were afraid of losing that. So I think that's something that we wouldn't think of normally as a potential effect, but it is.
Thank you. I'm Terry Brister with the National Alliance on Mental Illness. And just a couple of comments. I worked in community mental health centers for 20 years prior to coming to work for NAMI, and remember the days of Haldol and Prolixin being it, and you automatically got a prescription of Cogentin. So just to put this in context, it's sad for me personally that 40 years later we're having this discussion about a medication to treat the side effects because we still don't have the great medications to treat the actual illnesses. In echoing the comments that he made about concerns about aims and the fact that it is objective, there isn't a good tool out there. So I applaud the folks who are trying to make the comparisons. There's really not a good tool out there that does get at what is quality from the patient's perspective and from the family's perspective. And also want to make the point that we're talking about a medication that treats symptoms that have surfaced as a side effect of another medication that's treating symptoms. We don't have anything curative for mental illness. We don't. So it's hard to have the conversation comparing apples to apples when we can't compare it. There's not a curative comparison, if you will. And I think about people who, when all of the attention first came around, I'm Director of Information and Support at NAMI, do our education programs, providing family members and care and individuals with illnesses about things like what new meds are out there, what should you know, what should you ask your provider, how do you have the conversation. And several months ago, when all of the energy was around the FDA approval of these medications, I had that moment where I thought, this is such a tiny percentage of the people that we see and that we hear from. How much time can we spend on promoting this? And I'm being honest. But the reality is, our job at NAMI and at other organizations that are looking after the interest of family members and caregivers is anybody who needs it, regardless of how small the percentage is that they fall into. If it's disrupting your life, If it's interfering with your ability to even go out in public when you're already dealing with the stigma of having a mental illness, it's worth being able to have access to treatment for that. So again, just a couple of reminders. Thank you.
2 quick points. One was, I honestly don't know the answer to this question, but maybe you've come across it. Published studies on the validity and reliability of the Ames test, they're out there, are they? Does anybody know? I know that years ago, I was working with somebody at Boston State Hospital, and we looked at videos of people with TD, about half a dozen of us, all of us pretty experienced, and the agreement between us in scores was shockingly low, and we thought we knew how to interpret what we were saying. The second point is, I should have mentioned earlier, I mentioned this a couple of people during the break, is the major impact to me of these 2 new drugs coming along has been now people know what tetrabenazine is all about, or will know. Before this, the usual reaction, if I used that word tetrabenazine to anybody, including a neurologist or even sometimes psychiatrists, is what? And what is that? And, oh, yeah, I heard of that. That's a dangerous drug that we sometimes use, but you almost never have to use it. So I think this is a real benefit of having these out there and having them destigmatized and recognized for being effective in certain situations.
Yeah, hi. So in the interest of full disclosure, I'm going to say, I do give talks, CME talks, about various topics, including tardive dyskinesia. They're often funded in part by drug companies, and Neurocrine, I believe, has funded at least one of those talks, at least partially. But what I want to emphasize is, when I came to this country about almost 30 years ago, I started out in a state hospital where everybody was treated with tardive dyskinesia, with first-generation antipsychotics, and it was striking. You walked in, and people were clearly stigmatized. I mean, there was no question that they were treated, that they had a serious illness, and they were treated with something that gave them side effects. If you come to our clinic today, I work in a community mental health center, typical outpatient clinic in downtown Boston, the Lindemann, if somebody knows it here, has vastly changed the picture. Doesn't mean that tardive dyskinesia has disappeared. It actually has not. But it's clearly with the advent of the second generation antipsychotics, because there's still discussions in the field how much better they actually are. I think the one thing I can say clinically, it has changed what we have to worry about. And yet the concern and the worry has not gotten away. And that was a little bit the point that you made. Well, if you end up having TD as opposed to not, that's pretty bad for you personally. And while for the whole population maybe it's no longer such a huge issue, even though I actually do believe for those people that I treat it is, in individual selected patients it can be huge. So any studies that you see or analyses that are based on populations, is a little bit always this question, well, that's fine, I get it, but what about if there's an individual patient who would really benefit from this? The literature, I think, is on the one hand, it's actually pretty good. Looking also, we saw that for tetrabenazine, there doesn't really seem to be much evidence in the way we actually look for evidence, like randomized control trials. With these newer medications, they were approved based on fairly rigorous trials. It's actually hard to argue with the numbers. We might say the Ames is not ideal. We use it all the time in psychiatry. It's kind of one of those few tools that we have in the spirit of measurement-based psychiatry, measurement-based medicine. You can actually do it. And you personally, if you do it, you can get pretty good. The problem is if you have 2 people and everybody's idea of what severe means is different, then you get very different ratings. That's why what the companies did with this group of raters who basically had the same gold standard, what severe actually means, they could show the effects. One thing that is completely overlooked that we haven't addressed at all, at least in patients with schizophrenia, if you look on the Ames, the full, not just the additive items for the symptoms, there's one item that is labeled, I think, awareness of unawareness of symptoms. A very significant minority, or maybe most patients, will actually be quite unaware of their symptoms, which puts me in this funny position that I ask them, well, did you notice, or, are you troubled by it? And they say, what are you talking about? So using this any subjective measure in a population that might not actually see that there's a problem, I think leads to what you saw here, that you have the numbers all over the board, with placebo response versus drug response. So to me, that's actually no surprise there. And it is definitely not something that I would have used. Secondary is fine, but it's really hard to base any assessment on that, I believe.
Thank you very much. So we'll have further discussion of this during the policy roundtable. So I'll turn it over to Celia now to lead us through the voting.
Sure. So members of our CEPAC should now be currently logged into our voting software. And I want to get a sense, is everyone logged in?
Not yet.
Not yet. Okay. So there should be instructions in your packet on how to log into the voting software using either a browser or your phone. And I will remind everyone to just log in using one device. One person, one vote. Okay, that I'll stay with you. Any CEPAC? We all set? All right. So I'm going to walk through a test question so that you all can get a flavor of what the voting will look like. What famous historic event in American history occurred on December 5th? The bombing of Pearl Harbor, the first day of the Montgomery bus boycott, the creation of the light bulb, the Emancipation Proclamation, or the Tear Down This Wall speech? What was it? All right. We're still waiting on a few others. One more. I think we should be still waiting on one other person.
Submit, or you just...
No, you should just hit the letter. Oh, we have everyone. And the correct answer is, well, no, it's the first day of the Montgomery bus boycott. Pearl Harbor was in 2 days, on December 7th. I actually stumped people this time. All right, and with that, I'll bring up Steve Pearson, who will run our voting questions.
Yeah, that was hard. All right, December 5th is now the day that the New England CEPAC lives in infamy for not knowing that it was December, for not knowing it was December 7th. All right, so what we will do for the next hour, approximately, a little bit less, is to revisit the evidence, to think hard about it, to deliberate with the CEPAC, with the availability of the clinical experts, the patient representatives, and the ICER research team who are at your disposal. So we have several questions to start off around comparative clinical effectiveness, and the first is this. Is the evidence adequate to demonstrate a positive net health benefit? That means net not in a financial sense, but net in terms of risks and benefits, clinical benefits, from treating patients with tardive dyskinesia with valbenazine? Yes or no? The tables in, sorry, move away. The tables in, can you hear me? Yeah, as long as I don't hit this. The tables in your evidence summary are on page 5 that reflect the specific findings on valbenazine. And let me just invite Steve Atlas again to very briefly just summarize the key findings on the comparative clinical effectiveness of valbenazine. And again, this is versus no treatment.
So I don't have the tables directly in front of me right this moment, but I apologize. So the table 4 is presenting the primary outcome, the Ames response, and showing that there's a clinically meaningful and a statistically significant decrease in the Ames score between baseline and 6 weeks in intervention patients, absolutely, and that difference is significant compared to controls, and that there's a similar improvement in the 50% or greater response to that question. And then the second table is looking at clinician and patient responses where there are not necessarily statistically significant differences, and there's in one trial, but there is in another. Generally, there's a trend towards improvement with the intervention, with the exception of the one trial where there was a lower patient response to the high dose of the valbenazine, which is not necessarily intuitive.
Okay. So, further thoughts and questions from CEPAC about the evidence? Yes, Greg.
Did I hear Dr. Tarsi correctly? I know he's not in the room right now, but did he raise some concerns about the analysis of the videotapes? Did I hear that correctly?
I wouldn't say he raised a concern. He raised a question about whether there was
reproducibility,
reliability. Yeah, whether there was.
I would say that he and other doctors would look at the AIM score, look at a videotape, and give different AIM scores. So there's an interrelator problem he was talking about. But in these trials, the same people observed the tapes before and after, which would alleviate some of his concern.
Yeah, but I don't know if it wasn't a committee doing it. Was it a single reviewer? Do you know? Does anybody know?
He could probably answer better than me.
The company would know.
It was 2, and it was a consensus score. They had to agree on the score.
Okay. So 2 trained observers, and they had to come to consensus on the score. And again, blinded, obviously, to whether the patient was or wasn't on the treatment. Okay. Other questions about the evidence in front of you, risks and benefits? Jean, did you want to ask something?
Not so much a question about evidence, but before we vote, can we revisit the word adequate?
Adequate is a term of art. Right? It basically means that you get to weigh in your own scientific and to some extent value judgment around certain things such as precision of results. When we think of strength of evidence, we think how consistent are the results, right? Do studies find the same general finding? Do we have a pretty precise idea of how much benefit there is in regards to the risks, for instance? Do the patients represent the patients who will be treated in the real world? Are there some kind of issues? And fundamentally, you start with, are there inherent biases in the study design? Here we have randomized control trials, but that's usually where you would start. So it's looking at that mix of factors that go into thinking about the strength of evidence, and you have to think about it both on, again, the clinical gains that patients may have and the risks, because you will often have different levels of certainty around benefits and harms. Brian.
A question about subgroup analysis. Schizophrenia often comes on in adolescence, but the mean age of the people in this study was in their mid-50s. So I'm just wondering if we have any idea of the net benefit in younger age groups than the 50, 60-year-olds.
Someone made a reference to subgroup analysis by age. Do you remember, Steve?
Right. So there's one poster presentation that we reviewed that looked at stratifying, I believe, based on age. I think it was greater than or less than 50. And I don't have the numbers exactly, but the key conclusion was that the magnitude of benefit in younger age populations and older age populations was similar in terms of the benefit on the primary outcome.
Okay. Any other key questions? Claudia?
Yeah, a question that I'm sure was in the main report in regards to, in the study, how many patients dropped out due to problems with side effects from the medication?
Which study are you talking about?
The studies that were based on that with the valbenazine study. Because there were significant side effects mentioned, but I'm not sure I'm curious about the dropout rate.
Felucio knows if you don't happen to, Steve.
Yeah, so Table 9 on page 8 presents the adverse events, and the one that you're commenting on is the discontinuation rate due to an adverse event. So those are presented, so 4.5% for valbenazine versus 3.2% with then rates in their long-term extension studies, the weights out to 48 weeks of 13.4% for the 40 milligrams and 17.8% for the 80 milligram dose.
Thank you.
So as you will remember, the ICER preliminary rating, if you will, was promising but inconclusive. And you remember the discussion around how that was kind of judged at the time. Before we vote, would anybody like to suggest their rationale for a yes vote so we can flesh out some of your own thinking among yourselves before we take the vote? Anybody preparing to vote yes, willing to say why? Don't all jump in.
All right, I'm not shy. I'll jump in. I think the percentage of patients who had a greater than 50% reduction in AIMS is important and looks very convincing and would indicate a health benefit. So I think that, to my mind, that's the most important issue on this table. And we've heard from others that the patient recognition of their own symptoms may not be very good, so I'm not sure that I'm turned off by the insignificant changes or even negative effect in the patient reported benefits of the drug.
Okay. Anybody else voting yes have anything complimentary to say? Steve?
Well, I've asked this question before. Sure. With respect to net health benefit, and you'd asked that we do not include safety and risk of harm in that calculus. Is that correct?
No, it's absolutely what you should. Don't include financial considerations.
Okay.
But here, net health benefit means, think of, unfortunately, we still use that word benefit, but it means the benefits and the risks or harms.
So the lack of long-term information about suicidal ideation may be...
That will be part of your factoring in this question. Anybody else want to say about yes? If not, invite someone who's going to vote no, if there are any who would like to give their rationale to help other people think it through. Okay. Nobody's going to vote no. Kim, did you want to suggest something?
I'll give some rationale for people to think about. I think I'm hung up a little bit on the adequate evidence because while we have evidence that the primary endpoints were met in the clinical trials presented, I think there is some discussion as to what the clinical significance is of the AIMS score difference, even though it met statistical power. And the secondary endpoints, while maybe not powered enough, were not statistically significant. And I think looking at the side effects, the long-term trials, looks like there was a significant dropout rate due to side effects. So I'm not convinced that there's adequate evidence to suggest that there's a net health benefit.
Now, we haven't talked that much about the clinical significance of the findings from the trials, the 3-ish point change in the AIMS. I might ask the clinical experts to comment a little bit on how you think the CEPAC should interpret average AIMS changes in the context of whether it represents a net health benefit.
There is an abstract or a poster looking at what's called MCID, significant clinical change, basically, and comparing an improvement in the AIMS of 3 versus 2 was felt to fall within the range of a significant clinical benefit. It was published as a poster. It hasn't been published peer-reviewed.
Okay. Oliver?
Steve already alluded to this. The problem here is that the total score basically sums up various body parts. So there is, as opposed to other scores that are somewhat linear, it's actually not so clear how to truly interpret a mean score for this scale, because somebody could have just the typical TD with the tongue and the perioral area involved pretty bad, to the point that they can't speak, they have a hard time eating, and it would be very visible. They would have a score of 4, for example. And then somebody else who has a little bit TD here and there might have a higher score, but it actually wouldn't be noticeable and wouldn't be impairing, just because the person might just look a little hyper to everybody. So I think there's a real limitation that it is some score that is not linear. So more severe doesn't necessarily, you have to take that into account with the various body areas affected.
Patrick, I would just invite you. You commented on this in your own comments, but if you have anything else to add before the panel votes, please do so.
Again, I just think that the AIM score is so relative. I mean, exactly what he's saying there, that, you're talking about severity of impact. And so you're trying to make decisions about, a medication that may have a change in one aspect of impact. There's been no discussion really, do the medications affect different types of movement more than other types of movement? So it seems like there's a lot of vagueness around the AIMS score.
Steve, yes.
Maybe just to comment further on the study that Dr. Tarsi had mentioned that I referred to earlier. There's, the challenge is there's no gold standard on which to compare, and what the study did, to at least my understanding of the abstract, was to compare these global response measures to see if someone who reported very significant improvement, these secondary outcomes that we presented, what was their change in score. And so that's how they arrived at this 2 to 3 point change as representing what would be considered a minimal clinically important difference. So it's a kind of a backhand way of getting around the fact that we don't have as the others have mentioned, a true gold standard, though it gives you a sense of that the changes seen, at least in these studies, fit into that self-perception by patients and clinicians of what would be important.
Austin.
I just wanted to point out, I've made some comments and others have, that there's, for the CGIC and PGIC, there's a lot of numbers that aren't statistically significantly different from placebo, but there are some that are statistically significantly different. So it's not a consistent finding across all the studies, but there is a signal in some of the results.
Okay. Jean, did you have a comment or question?
I'm thinking back to previous reviews on and how we handled issues of long-term, unknown long-term risk. Mm-hmm. And I am finding I am struggling with the binary nature of yes versus no.
Yes, you are. And as you know, in our contextual considerations, we now have a specific vote on significant long-term uncertainty about risks and benefits. So there will be that aspect to be able to vote on. A little bit more on this, and then I'll try to move us through so we make sure we have enough time for some of the other questions. But this is helpful to spend more time on this first question, because a lot of the questions about the applicability of the clinical outcomes, et cetera, will be the same for all of the questions. Yes, Ed.
I'm struggling with the bent over backward posture I feel myself in. I want there to be an answer. I want there to be something that is helpful to people who are suffering, and I'm really trying to see that benefit here. And I clearly want to recognize the difference between the two newer agents and the tetrabenazine. But I'm not sure I want to say there's adequate evidence to say yes to question number one. If I say no, is there an opportunity to say later that, if you had to make a choice, I'd rather choose one of the newer agents than the tetrabenazine?
Well, you don't get to make that statement, but I'll ask the clinical experts. How about that?
But can I actually emphasize what you said? Because that's what I struggle with as a clinician. I want to know in the end, do I have a patient who might, when taking this medicine, have zero abnormal movements? because he takes the medicine, which would be huge, potentially? Or is it for most people that they, for better or worse, it doesn't change, their ability to function in society. They go from moderate to severe, or they improve a little bit, and then people would say, well, so what? And you have all these risks from the medicine. So there are, you alluded to this earlier, a lot of unclear answers, I think, to the question who benefits from this, and to what extent are there subgroups that we have to be careful with the yes, no, because we would deprive an important subgroup of patients with a potentially valuable treatment.
All right. I think we should, Greg, if it's quick, I hope.
I would just add that, I am inclined to vote yes on this, but the caveat is that I don't think it should be the first intervention. Based on what the experts have told us. Maybe the antipsychotic can be discontinued or switched. And I think we do those things first.
Right. No, I appreciate the real worldness of your thinking, and we're going to try to keep the question on the voting, I should say, anchored on the evidence, and then your specific point as Ed's will also be front and center in the policy roundtable, because we're going to want to know how the evidence should be applied to practice and to coverage. So, and those points will definitely come up. All right, I'd like to try to move to a vote to make sure we have time to adequately discuss the others. So please go ahead and enter your vote. Is the evidence adequate to demonstrate a net health benefit of treatment with valbenazine?
He's got a problem over here.
We have a problem. Oh. He has no buttons.
I can't vote. I've been locked out.
You haven't gone down from it?
We're waiting for 2 more votes. Brian is one of them. Everybody else. Has anybody else not voted yet?
Downloading time.
Okay.
All right, I voted.
Well, I can show the results now, and then we know how Brian votes. All right, we are set to review the results. 11 yes and 4 no. All right. I think we've had a really good discussion of the rationale behind these votes, such that we can move on at this point and not do a deeper dive at this point. But we can always come back if people have specific aspects of their voting that they want to have captured in the record. So let's move to the next one, which is the same question. And do tetrabenazine. Steve, very quickly again, just lead them, if you will, through the... And again, this is not dutetrabenazine versus valbenazine. This is dutetrabenazine versus no treatment. Steve.
Sorry. This is page 6 tables, 6 and 7, the same outcomes. Basically, dutetrabenazine had a similar change in the AIM score between baseline and follow-up. This was a 12-week follow-up, and the 50% improvement in the AIM score was also statistically significant, greater than the control group. The secondary outcomes, as mentioned previously, showed a trend towards benefit with the active intervention, but most of them did not meet statistical significance.
All right. So is there any reason from your perspective that the evidence differs on dutetrabenazine in a kind of a qualitative sense from what we've just talked about with valbenazine?
Right. I think our internal deliberations was that these were the evidence is very similar between these two drugs.
Thanks. Any questions from CEPAC? Yes.
Not a question so much as a comment. I think it's important to consider that this medication is dosed BID versus once a day as we consider adherence.
Again, that will bring that up specifically as another benefit as well. Any other questions or comments where people feel like they need to parse their thinking here? Okay, please go ahead and vote. Waiting for one more. There we go. 10-5. All right. I'm not going to ask the person who flipped their vote to identify, because I think the policy context is clear enough with the kind of trend of the voting, if you will. Don't you love it when evidence-based people can look at something and say there's a trend when they want to see one? There we see a trend. So let's turn to tetrabenazine, the drug that's been used, as we've heard, off-label to a certain extent. Steve, why don't you, again, try to summarize the status of the body of evidence?
So this is Table 8, page number 7. We did not go into great detail about the individual studies, the 8 studies. These are all non-randomized studies. As mentioned, the populations vary in terms of size. The methodologic rating for these would be considered low. The outcome measures are not standardized. I believe there was 1 or 2 studies that actually used the AIMS score. Most of the studies did show improvement in symptoms in those individuals who were treated with tetrabenazine. There's no comparator group. As said, there's no placebo. Though because of the quality of the studies and the lack of comparison, we rated this as being insufficient information.
Okay. Use of tetrabenazine will come up on the round table no matter what the vote is. Questions from CEPAC? Jason.
Steve, I had a question about, so as you well know, the one of the concerns about these observational non-randomized data are that there can be selection biases in real-world data, and I'm just trying to understand the potential directionality of that selection bias. Maybe this is also for the panel generally. Are there reasons to believe that either treated or non-treated patients would be more or less sick in a real-world setting? Maybe also for the
I think that's more getting back to the randomized studies. I guess flipping your question would be saying, are these studies more representative of patients in actual clinical practice? And my guess is that these studies were generally small, single-center studies that would likely represent patients who were being under the care of the psychiatrist or the neurologist who was caring for them. So there may be, in effect, some greater generalizability, but the difficulty is the way they collected information was not as systematic and as thorough, so that's an inference as opposed to a definitive statement. I don't know if
maybe I'll answer it indirectly. The question if in these the valbenazine and deutetrabenazine trials were these typical patients, well, the setting is artificial, right? It's a clinical trial, so that comes, with all kinds of changes that get introduced into clinical care, which it's not. But I have to say, I believe that the patients with tardive dyskinesia, where they're going to come from, they are typical patients. And it might be different from some other clinical trials in schizophrenia where you have to rely purely on self-report and the professional patient, because here you actually have something that's objective. So if anything, I actually do believe that these trials have helped me understand a little bit better who's actually out there and what's possible. I have greater problems with the tetrabenazine literature because that really comes mostly from neurology and not psychiatry. Wasn't the question?
Does evidence? I wasn't here. I'm sorry that I stepped out to take a call. Evidence means in the literature, in clinical trials, or evidence, meaning what I call evidence. Because I agree, the clinical trials are non-existent. I mean, they're poor. They're retrospective, experiential, experiences of relatively few clinicians that publish those papers. I've used tetrabenazine for years, and there's no question in the world that it benefits patients with tardive dyskinesia. I mean, it's just very predictably. Occasionally you run into side effects and they can't take it anymore. That's the only thing that does happen sometimes. But in patients that can take it, it's very, very helpful.
So the short answer to your question is for their votes, we want them to focus on the available published or
so I would say
but
want my vote?
But what that means is that we
won't count it, but you want to know what I would have said?
I'm going to ask you that question after they vote.
I don't want to bias anything.
Completely fair, and it will be brought up. It will be brought up. Apologies, I jumped ahead, and clearly we already have a horse race in this question, but other people will be able to vote, I think. Celia, if that needs to be redone, just let me know. Well, it's because I probably pushed that forward when there were only two. I just want to make sure that the other responses will be able to be mapped.
Yeah, I might have to, let me restart this question.
Sorry about that. Any other questions or comments? Yes.
Well, I guess it's related to what you just said, is what I was going to ask and also comment on, is the use of clinical expert opinion. I mean, certainly we have so many situations in medicine where a medication has been approved for one indication, and yet we have tremendous experience in using that medication off-label. I would like to be able to use clinical expert opinion in my analysis for this question, unless it's deemed to be completely inappropriate, because I think it's a real-world situation that we run into all the time.
All right. Another careful attempt at framing this is that everything you wish to consider is fair game. How you weigh them, how you would weigh expert opinion versus the published literature, is also a judgment that in the end you can make. So we are not saying that you cannot consider expert opinion or your own clinical expertise, if you will, or experience. But it's up to you, too, how to weigh that in. Leave it at that. All right. I think we will hopefully be able to get back to the voting question.
All right.
Other comments or questions? Greg?
I probably should say this for later, but the obvious issue here is that since there are generics for tetrabenazine, I assume that the cost is much, much lower than for the FDA-approved drugs.
You're right on both points.
And,
yes,
if Dr. Tarsi is correct that this really works, the problem is solved, right?
There's I've had a couple of patients who have been told that they would ask me to write for the generic after they'd been getting Xenazine, which is the trade name for tetrabenazine, and they've been getting it at a reduced cost because of their process they go through, all three companies do, and it turned out that the cost of the generic was higher than what had been the negotiated price for the trade name brand. I don't know how common that is. I've had two cases like that.
That happens, yeah.
So we will,
can I just say that...
on this point, I want to hold it for the policy roundtable.
Yeah.
It's so central
right.
to the discussion
Yep.
there. All right. Other questions about the evidence on the clinical effectiveness of tetrabenazine before the vote? All right, please go ahead and complete your voting. Just waiting for two more. Help me just by people still voting, two people still yet to vote, yes?
Might not know it since it got restarted.
I wonder. I think it only is going to count 13. Nope, now it went to 14. There we go. All right, 13 no and 2 yes. All right. Let's keep going. I'm sensitive to the importance and the challenge of discussing some of the other voting questions. And again, I think we have had a chance to talk about some of the pros and cons on this one. So we have one more question before we move to other benefits, and that's the question about distinguishing. Is the evidence adequate to distinguish between the net health benefit of valbenazine and deutetrabenazine in the treatment of TD? I'm going to take moderator's prerogative and assume that this will require little conversation because of the previous votes on the two. But I do want to open the floor if anybody feels like they want to ask an important question for their own thinking or make a comment that they think is particularly important. Okay. If not, please go ahead and vote on whether the evidence is adequate to distinguish between the two. Just waiting on 2 more responses.
I'm having the same problem I had before, not having a button to push.
All right, yeah, we're just now waiting for the one. Okay, 14-1. All right. I will ask, since it might want to be noted, but one person thought the evidence was adequate to distinguish between the two. Unless it was that, if they did mean to vote that, would they please tell us why? Yes, Steph.
So my thought here was that the placebo response to deutetrabenazine was a lot higher. It was like 1.5 or so versus a response of 3.2, 3.3. So I thought the delta was actually a lot lower. I wonder about the clinical significance of 2 points, but then I even further wonder about the clinical significance of like 1.5 points. So that was the reasoning for me.
Okay. All right. So let's move to the discussion around other benefits. Now, this looks like a complicated slide. We are going to go through each of these, but we're going to vote on them all together. So just hold on for a second. So again, this is our effort to make sure that we cast a broad net on considerations of value. So the question is framed: does treating patients with one of the new FDA-approved drugs, valbenazine or deutetrabenazine, offer one or more of the following other benefits? Select all that apply. A, this intervention provides significant direct patient health benefits that are not adequately captured by the QALY. B, this intervention offers reduced complexity that will significantly improve patient outcomes, etc. I'm not going to read through them all because you've got them both up there and in front of you. So I'm going to try to entertain, obviously, discussion of these and try to kind of manage it so that we can get through these and the contextual issues as well.
Good questions.
So, A, this intervention provides direct benefits, health benefits, to the patient not captured by the QALY, which would mean that the cost effectiveness is somehow misjudged. We're underestimating the impact on health directly to the patient by the way that the QALY, either the length of life or here it would have to be quality of life, was captured. Anybody want to make a comment or a question about that to the experts? Yes.
Yeah, also struggle, as other people have mentioned, on the binary characterizations of this. So all of these sentences have the verb will, and it would just be a lot easier if it was may, but I realize you want us to make a decision, but it is just adds to the challenges of making decisions when it's will, which is a lot more binary than may.
We'll talk about the mays afterwards, but yes. I think
but if it's not a will, then it's got to be no, right? I mean, you can't say.
That's correct.
If you don't think it is a will, then you have to kind of. If you think it's a may, you can't vote. You shouldn't be voting will, or whatever. You know what I meant.
Right.
It didn't sound right, but.
So does anybody see among the six? Obviously, we're going to let you or ask you to vote for any or all that apply. Does anybody see one that jumps out at them that they want to convince their CEPAC mates that this is one that should apply to these treatments? Gene.
So I have one that I'd like to add, but before I do that, I want to raise a question from the comments about the lack of true patient-reported outcomes in these studies, or in fact, most of the randomized clinical trials that we review here. And while I would not call into question the quality, which I love, the lack of patient-reported outcomes is a real issue for me here. The one I would like to have you think about, though, because I come from the northern part of New Hampshire, is that there are going to be geographic disparities there are acute geographic disparities in access to psychiatric care, to neurologists, to mental health care in general. And so I see a regional disparity here that is, I agree people don't get TD without having been prescribed antipsychotics, but they may not be getting the level of psychiatric care and oversight that would allow good clinical decision making.
So I think our job here, or your job, is to think through whether the new treatments versus what has been available will have a strong impact on that. It exists, but will it improve it? Will it make it better somehow? Will it make it worse? We've asked about it from a benefit perspective. Would it improve that pattern that you just described, the introduction of these new drugs? If it would, that's what we're wanting to capture here. Ed?
I'm going to make a case for E.
Okay.
Just because I'm still looking for something positive to say. My standard of evidence is lower for these kinds of questions, so I'm going with the expert opinion that's been voiced this afternoon that allow me to give E a positive.
All right. Yes.
Steve, I want to advocate for A, in that I think that with a population like this, which already suffers from social isolation, the stigma associated with TD can be enormous and difficult to quantify. So the ability of these medications to address that, I think, could be an enormous benefit that may not be fully captured.
Okay. Again, I thought we had a very good discussion earlier about sometimes, the best you can do is to give, the patients themselves the chance to express what it's like to live with a condition, or to give people as accurate, or clinicians as accurate a picture, and to ask what are the benefits or the downsides of having that condition. So it's hard to know because there's no gold standard, but I hear what you're saying. The other thing that may come up also on the policy roundtable, because Ed raised it, point E suggests that this may provide a mechanism of action that would allow patients to be treated who couldn't otherwise be treated. Well, maybe I'll hold it for the policy roundtable, because we'll talk about tetrabenazine again, about whether patients who don't respond to tetrabenazine, would they be tried on deutetrabenazine? Is there a reason to think that clinically that these agents would offer a new spectrum of responders over the tetrabenazine, given that it's the same mechanism of action? Why don't you go ahead and answer that question, since I went ahead and said it. Do you have a view on that?
This is what I wanted to say earlier in response to what you said. If it's tetrabenazine is cheaper, problem solved. No, it's not solved. Tetrabenazine, no psychiatrist is going to prescribe it because we haven't. And the reason for that, it's not approved for the indication that it's off-label. There's a black box warning of suicidality, and it's perceived as a very difficult drug to use. So in a way, what is exciting about these newer medications is that they're much more simple to use. I started out by saying, I've started to give talks about tardive dyskinesia. I haven't given talks about tardive dyskinesia in 20 years. Why now? And that is your point a little bit, because I think, and maybe it shouldn't be that way, but new treatments sometimes lead to a reconsideration of fairness in treatment and who deserves what. And so I do think it's an opportunity to provide more equitable health care by educating maybe psychiatrists again. I would have a hard time, though, if it becomes that we have to try tetrabenazine first before we can try the newer ones. Then we lose what might have been an opportunity to actually improve care, because then we have this very, I believe, this very high hurdle.
All right, we'll absolutely coming back to that again. The last comment I would want, at least one more to invite, One of these says that this intervention will significantly reduce caregiver or broader family burden. Anything from the patient perspective? We've heard a little bit about that, but anything you would want to?
Well, and from the caregiver's perspective, and it was mentioned earlier on, there's no data out there. There's nothing measuring this. The reality is that whether you're a caregiver of someone with a mental illness or whether you're a caregiver of someone with cancer, they're going to be more med compliant, med adherent, if the meds aren't causing them more trouble than it seems like they're helping. So it does seem logical, and it's an inference is the other word that's been used, that the lives of the people who love the individuals with mental illness and who are watching them suffer and isolate and feel ridiculed when they go out in public will improve when the symptoms, when those side effects go away, which will make them more likely. Caregivers live in fear of when are they going to stop their antipsychotics? When are they going to go off their meds? When are they going to go in crisis again? This is one less thing you have to worry about if this can be taken care of.
All right, thank you. All right. Got another set of questions to vote on, but anybody else want to make a strong claim for something they want to make sure that people do or don't vote on here from their perspective? No? Okay. Go ahead and please vote then for any of those, all of them, that you feel apply when considering, again, either of the two new FDA-approved drugs, what other benefits. And I'm not sure how I keep track of how many votes we have here. Oh, I've got 15 already, so maybe that means I do. Has everybody voted? Just want to make sure before I... Okay. Here's what we've got. Oof, hard to read. So 8 out of 15 for A, then 3, 2, 3, 12 for E, and 5 for F. All right?
Can I make a quick comment?
Sure.
I don't know if this is a point in which you can make notes that will be reflected in the report, but I think it's going to be very confusing for an external party to read this report and see that 12 people thought that one of these new drugs is a novel mechanism of action compared to tetrabenazine. And the way, if you read the question, the way that it reads, it's one of the new FDA-approved drugs, which would lead you to believe you're supposed to only be voting with deutetrabenazine and valbenazine.
What we should do, to be clear, and I probably should have done it verbally, is that we had intended these votes to be taken in comparison to no treatment, so not to tetrabenazine as the comparator here. So that's a very important distinctive.
Yeah.
And tetrabenazine will probably be the word that's mentioned most in the policy roundtable. So hold on. Next to price. All right, we've got one more set of things to vote on. These are what we call contextual considerations. All right, so this is, again, kind of the broader landscape, some of these, and some of them also have to do with uncertainty. So are any of the following, and this is the same thing, select all that apply, contextual considerations important? So are they important in assessing these drugs' long-term value for money? You can see that A is about whether they are this condition is of particularly high severity in terms of its impact on length of life and or quality of life. B is about whether it's involved with a condition that represents a particularly high lifetime burden of illness. That means usually both severity multiplied by time, by number of years. C is about whether this is the quote-unquote first to offer any improvement for patients with this condition. D is about whether there are, compared to usual care, significant uncertainty about long-term risks of serious side effects. And E is about the significant uncertainty about the magnitude or durability of the long-term clinical benefits of this intervention. These are very broad, some of them, hard to get your head around, but I know you've already been thinking about these for quite some time. Does anybody want to offer, again, a perspective that they've arrived at that is going to kind of target their voting on one or more of these that they'd like to share? Again, make an argument for or against any of these in particular? Yes?
One of the issues with my first votes was the concern about D, about the long-term risk, and actually that sort of flows over into E. We don't know, really, do we, that this is a durable result, that this might not change over time. One will hope, but I don't know that we have any evidence for that. So those are things that push me into levels of concern, but the condition is serious and difficult, and people need relief.
I'm going to have to qualify C here in some way for
Thank
you.
you.
Yeah. I'm not really sure what's the best way to capture, because the issue is we want, it's almost not even worth taking a vote on it, but we have to clarify whether you're voting versus as if there was no other treatment out there, or whether you're allowing the off-label treatments that have been used.
Can you be consistent with the prior question?
I know. That would be the simplest thing.
Well, otherwise you have a lot of experience.
I know, I agree. I think the simplest thing would be to do that, but we have to, again, asterisk it by making it quite clear that there are off-label treatments that are being used, not just tetrabenazine, but others. And so in some ways it's not the first to offer any improvement, but it's the first on label, certainly, to offer improvement.
But the other aspect of this, I think, Steve, is that we were presented evidence that switching to second-generation agents for the treatment of the underlying disorder also resulted in improvement. Right. So would that be considered an intervention that would treat this condition?
Ooh. Hadn't thought of that one.
Uh-huh.
Yeah.
Uh-huh.
I'll leave that to your discretion. I think you could argue it either way.
So I'll offer my logic for lumping the three treatments in condition C, in that having randomized trial evidence of two agents gave me comfort in that there's a class effect for all three agents. And so that's my excuse for lumping and saying all three of them are one intervention. If that makes sense to anybody, you might use the same logic.
Steve.
Just wrestling with A little bit with respect to impact on length of life and or quality of life. Hearing TA about the varied presentation of TED. Some patients may not even recognize they have the condition versus others that we heard in some of the vignettes from one of the presenters this morning that basically life-changing, these medications. And so makes it difficult to answer question A, I think.
I would say we should capture your comment, because as I hear it, it's this is one of those conditions where, if I'm interpreting you, tell me if my words are okay, the range of severity is so broad that there are some patients for whom it is absolutely very severe. And that just needs to be noted that, as you said, for some patients, and you haven't seen the videos, or some of you have, but when this is very severe, you can imagine that the person really couldn't function at all. And then if they're successfully treated, it can be kind of really life-changing, truly life-changing. But what's hard is that that's going to be the case for some other conditions as well. But I think it's worth capturing the distinction here. Some conditions, like even hypertension or something broadly described, in terms of its impact on people's lives, while you've got hypertension through the years, it's not as different in the way that it affects quality of life. I say that with trepidation with the cardiologist at the table. All right, why don't we go ahead and vote on this then? All right, please complete your votes. Select all that apply. Jason, you're probably the last. No, everybody voted. Maybe you already got up. That's why you got up. Okay. All right, here we go. Again, with the difficulty reading. Is the first one 9? 9. So 9 out of 15 said yes, that it's high severity, particularly high severity. 8. Lifetime burden of illness. 3 on first to offer. 14 out of 15 said significant uncertainty about long-term safety. and 12 out of 15 on significant long-term, uncertainty about long-term benefits. All right, so these votes, and hopefully the useful nuance that you've added through your comments will be added to the report. And again, we're told that this section of the report is highly valued by certainly clinicians and patient groups, but also by payers who actually view this as very value add to their thinking. So thank you very much. All right, we ready to slightly shift gears for Policy Roundtable? We've been waiting for this for quite a while. I want to introduce and invite back up, I should say, the manufacturer representatives who were here earlier. And Paul, also two payers. We'll introduce them when everybody comes up. So Paul Jeffrey and Barbara Henry. I hope Paul's here. There he is. All right, now I get to switch these two. All right, everybody else can stand up for a second, prevent those blood clots, and we'll get going here. All right. So I know a few folks had to. Oh, that's okay. Oliver's coming back. So I just wanted to introduce the couple of new folks who've joined the Policy Roundtable. First, though, the manufacturer representatives that come back up, Charles Yonan and, Victor Abler are back up with us. Joining us now are Barbara Henry and Paul Jeffrey. Would you folks please just introduce yourselves?
Sure. Barbara Henry. I'm a lead
Just
clinical
grab the mic
pharmacy specialist with Harvard Pilgrim Healthcare, which, as most of you know, is a regional MCO, about 1.2 million lives. My responsibilities include all things formulary management and utilization management.
Thank you. Paul.
Good afternoon. My name is Paul Jeffrey. I'm the Director of Pharmacy for Mass Health, which is the Massachusetts Medicaid program. I'm also on the faculty and staff of the University of Massachusetts Medical School.
All right. So I have a very fun list of about 8 big topics, and it's almost impossible to do that many in one round table, but we're going to try to do a variety of things, one of which is I'll get in front of you and bother you a bit. But the goal is to try to pivot and focus on the future. And the future is, how do we think of applying the evidence that's been discussed and the other benefits and contextual considerations? How do we think of pulling that together and in some way providing some guidance to clinicians, to payers, in the future to manufacturers and to patient groups around what can be done to most effectively translate that evidence into the healthcare system in a way that will improve patient care and help improve value and maintain costs in a reasonable way. So that's kind of the goal. And I was going to start, hopefully Patrick will come back too, but Terry, I wanted to start again to turn to the patient's perspective about the outcomes that we've been talking about, because it's so common that we end up talking in these kinds of meetings, and insurers and others who have meetings to talk about coverage, obviously, and they wrestle with how do these outcomes really capture what matters to patients, and what can we do going forward to try to improve the ability of research to capture what matters most to patients in a way that can translate through effectively into clinical practice and to coverage. So you may not know into the weeds, or maybe you do, about the AIMS, for instance. But there are patient-reported outcomes here. They tried, right? Now, the studies weren't powered to try to capture that. But I'm just kind of curious, what would be your perspective on what the field needs to do to improve the ability in this condition to get outcomes that really do reflect what patients and their families care about? Any ideas?
So many ideas. So many ideas, but no solutions. I mean, the reality is we need better instruments. Even the other instruments that were some of the other instruments that were talked about, like the patient global impression, it's global. You know, it's how you feel about how you're doing globally. And again, a facial jerk may be relative to, based on what's going on right now, that may be nothing compared to when I'm delusional. and not able to care for myself or someone else. So some way of measuring what's really important to the patient, what's quality for them, and the aims, and everybody almost to a person up here and out there has mentioned that it is very much, the inter-rater reliability is not there. If you're in a room and discussing it to come up with a consensus, that's one thing. But in a mental health clinic where the doctor's with the patient for maybe 10 minutes, and it may be a different doctor than they saw 3 months ago, and if you're just doing the aims, it's what do I see right now without taking a deeper dive. So bottom line is we need better instruments that have to take in what the patient considers quality of life, the bigger picture.
Right. So you manufacturers, you guys wrestled with this. I'm not sure if you were part of the teams at that point that were thinking about the outcome measures. I don't even know if the CGIC and the PCIG existed before your developmental programs started. But what would you imagine, either sharing experience of how hard it was to do this right, but mainly looking forward, how do we try to accomplish what Terry and others would like to have? What could we do, or what barriers need to be addressed in order to get better outcome measures?
Yeah, absolutely. Great question. Having engaged a lot of payers over the last couple of years, as well as engaging patient groups, physicians, all the above, our primary question was based on the body of evidence given burden, who would you treat? And it was a resoundingly similar answer, and it was the patient that asks for it and is bothered by it. That's our biggest challenge with the aims, is it's perception-based, and there are many payers out there that took a quick look at both companies' PIs and said we mandate an aims of X in order to get this. We have fought over and over again, and fortunately a lot of those that have been in the room have talked about it's apples and zebras. Somebody with a significant score of 4, you're telling me they would have to have 2.5 times that to access this drug. So prevalence numbers are scary a lot of times, and it's, these are the numbers of folks that we think have symptoms, but there's a fraction of those that are actually impacted by it that want treatment. So I always tend to flip that question around function. Who should get it? Those that feel like they're impaired. And who should stay on it? Those who feel like it's working. Patients self-select compliance based on whether their own value proposition and what's going on in their cost, life, day-to-day, whatever. They make their own value decision on whether that treatment is still of worth or not. So I don't think that is answering your question as a manufacturer versus maybe more a sane clinical thought process on that, having done a lot of formulary reviews in my previous life.
Yeah. Well, you kind of skipped ahead to where we're headed next, which in my mind, which is kind of identifying a sweet spot for appropriate treatment. What tools, clinical and otherwise, would we use to do that? But it's linked to this other basic issue, which is the instrument itself that we've got so far for clinical research. There are going to be further treatments for tardive dyskinesia, we hope, right? Because only 50% or fewer patients are getting kind of significant response even out of the new drugs. So how will future research do a better job of capturing the clinical, or are we going to be just locked into AIMS scores? Is that going to be what we have to do forever? And I'll come back to you too for Patrick.
Yeah, I'd like to make a comment. So, Teva feels strongly that there's a big gap in patient-reported outcomes. We see that there was significant difference in the AIMS score versus placebo, but what does that mean to the patient? And we really don't know. There's no TD-specific patient-reported outcomes. In our clinical trial, in our AIMS TD trial, we did attempt at looking at something that wasn't even related, but it was modified cervical dystonia questionnaire, which was a patient-reported outcome for another disorder, but it was included in one of the tertiary outcomes. So we feel strong that there needs to be more research on what the impact of TD is on the patients themselves.
Okay. Patrick, please.
Yeah, I think just to reinforce what they were saying, the ultimate goal for any of the treatment is to improve quality of life. And so you have to be able to look at that, before you can decide whether or not it's appropriate for a person to have a particular treatment. As he said, a person who wants the treatment is probably the person who needs the treatment the most.
Yeah. Do we worry at all about, because I don't know to what extent this comes up, but for patients with schizophrenia, for instance, or for others perhaps, what does the clinician or the payer or others think about the patient who has symptoms that make observers uncomfortable, but the patient's gotten used to them over many years and doesn't feel like their life is that impacted by them? But people who see them on the subway or on the street for the first time say, wow, that patient's got something going on. Is that a concern for how we design these patient outcome measures at all?
It is to a degree, but the ultimate decision of whether or not they're going to take the medication is up to the individual. So if the person doesn't want to take it because they don't perceive an effect from the medication, you're not going to make them take the medication.
And for me, my spidey sense went off that if I'm the family member or I'm the patient and I go to a physician who is concerned about the involuntary movements I have that I've learned to live with and don't interfere with my life, but he stops a medication that after years has finally got my mental illness stabilized, that's terrifying. So from that perspective, that's a concern.
Right. So you're both helping us keep fully centered in the patient's perspective on whether treatment is warranted, and that's where we should start. All right. Well, our final report will definitely grapple with this issue and identify it as a long-term challenge for the field of, for manufacturers and for the clinical research community, figuring out better ways. And ultimately, you're right, because as you could tell for the modeling, we had to make some pretty big leaps about improvement in AIMS scores and how that translates through into quality of life. Not huge leaps in some ways, but had to make some assumptions. And the more data we can fill in to really understand how the treatment affects quality of life, I think the better for everybody. Daniel?
There are several movement disorders currently that are assessed mainly by questionnaires, lists of symptoms, very qualitative, but they've over the years they've been broken down or expanded, I should say, to include more detail. So, for example, maybe this was already said. I thought it was said, or you said it. Why not take the AIMS, not throw out the baby with the bathwater, but the global judgments needs to be thrown out. Number 10, numbers 8, 9, and 10, which is severity, incapacitation. I don't know what the difference between those two is. And patient awareness. I'm not even sure what that means. And just have it, work, home, and social situations. To what extent does this disorder disturb you at work or prevent you from working? To what extent does this interfere with your participating in social activities? To what extent does this interfere with your behavior or ability to function inside the home, do housework, or do whatever, interrelate with your family? I mean, you could make up half a dozen of these. And it makes the scale longer, although you could shorten the scale by getting rid of the thing about dentures and getting rid of do movements disappear in sleep. Those are both useless. And, it would be a little longer, but wouldn't be a lot longer. It'd probably be more useful.
All right. Thank you. So we'll try to capture some of that. Not some of that, but we'll try to capture the need to hang on to the core of the AIMS, because one of the things that will help patients and clinicians and payers and policymakers over time is to be able to go back and compare older data to newer data, if you will, on treatments so that we can compare apples to apples. But ultimately, we need better outcome measures for the whole field. So let me move then and kind of capture then the flow through to where Charles was going. How do we, and I'll ask the clinical experts here first. Imagine that you have a job, you're hired for the day by the Medicare to create coverage policy for these new drugs. And the key question that you're asked is, who are the right patients? Who are the appropriate patients? Because let's assume that there are some patients that, we might not feel like is the right thing to treat with these drugs, at least first off. What are some of the ways that you would think about using the evidence to create what is an appropriate patient to treat? And if the question doesn't compute, feel free to say that too. But how do we decide, how would someone write a description of who the appropriate patient is to treat?
I think somebody with let's say, a chronic psychotic condition that's doing well on antipsychotics, but who's prevented from enjoying a qualitatively satisfying and normal life because of their involuntary movements. so that this is the barrier that keeps them, they're doing well psychiatrically. The barrier is the movement disorder. That's a person that needs to be treated.
Would you in any way, because I'll come back to what you mentioned, would you in any way envision using the AIMS or another tool to judge severity that would qualify for treatment?
No, I would, only if the AIMS was modified to have more detail concerning work life, social life, home life, whatever else you want to add. As it is now, no, it doesn't do that.
Okay. Oliver, what do you think?
Yeah, it's obviously a critical question here, right? I'm concerned in some ways to make it too difficult, demanding too much of a drug. Function might actually not improve, and there's a lot of social determinants why somebody might not go back to work or do something, and yet that patient, in a small community without movement or fewer movement might just have a better life. So it gets a little bit, and I think that gets conflated sometimes, because it's perception that with these drugs in psychiatry, sometimes there's a little bit, this is kind of cosmetic psychopharmacology. We wouldn't really need it, right? And I'm worried very much that we set the bar too high then, because it does not modify the underlying disease. And a lot of times, yes, is it possible that they take their medicine more regularly if they don't perceive side effects? It's all possible, but in the end, I think all bets are off. That can be answered, in a trial. So I'm not quite sure how easy it is to actually operationalize that. Mm-hmm. And so maybe we do come back to the patient wants to try it and see. Which might be the summation of all these forces in the end, and just one last comment: who decides? We always, we're used to thinking about psychiatric disease or care in America as kind of dyadic, right? It's the patient and the physician. Well, I think it's complicated with the more serious disorders. Patients might actually live with the families. The families should have a say. What's quality of life? Whose quality of life? Is it only be a subjective quality of life? Are there some objective aspects to it that other people actually should have a say in? For those of you who have children, if they just have candy and don't go to school, their subjective quality of life is pretty good if you ask them. But objectively, we have failed, right? So I wouldn't want to just eliminate completely any objective measure and certainly input from other people in such a scale to determine who's eligible.
Let me ask you a related question, and this is actually part of our approach to providing some guidance, I guess, to policymakers. But we like to try to ask clinical experts if there's an eligible population for these medications as defined by the FDA label. And I think, wasn't it 500,000 patients in the U.S. were roughly estimated to have? And was it 300,000 with moderate to severe? I don't even know how that where that estimate came from. But let's assume it's all patients with any degree of tardive dyskinesia. From a clinical expert perspective, what % should be treated with one of these new drugs? All of them?
My view is very simple. That's what I teach my residents. It's a time-limited trial. Everybody should be offered a time-limited trial. Somebody with just very mild TD to see if it goes away. Somebody with serious TD, how much does it get better? Does it get better at all? And then you reassess, and I think that answers the question that not everybody will want treatment, benefit from treatment, need treatment. I think the big problem is that the hurdle is high to get it to try it, and because of the high hurdle, sometimes when somebody's on it, everybody just seems to be happy for having somebody on it, as opposed to really being realistic about it. So it's setting it up kind of the opposite, almost making it extremely easy to give it a try, but really having to justify then why to continue, I think is actually the way I would go. Most payers do it the other way with the prior authorization.
Right. So Daniel, I'll ask you that too, but just a quick follow-on. So Oliver, I'll try to, devil's advocate, a patient who has really minor tardive dyskinesia, the unknown risks longer term for these drugs, given what we know about tetrabenazine and these with similar mechanisms of action. Every patient deserves a trial, or is there some threshold?
A trial doesn't mean that I say you need to have a trial.
Right, but if
I'm going to offer it as a reasonable, approved drug for this condition that they have. That's shared decision making, actually. telling them what is potentially available, and including the risk. And quite a few will say, don't bother.
I know that you would like to jump in, and then I'll get to Daniel. Would you like to jump in quickly?
Yes, and this is people send us their stories all the time about what they've experienced, what's happened, what helps. Ironically, the week before Thanksgiving, I got a story in from someone, 21, she's 21 now, was put on antipsychotics November of 2016, developed mild symptoms of tardive dyskinesia, face twitches, nose twitches, some tongue protrusion, nothing that was too debilitating. It was frustrating. She's young, okay? So again, would not have fallen into any of these traditional categories we've been talking about today, had not been on antipsychotics that long, was not a long-term patient. There wasn't anything to treat the tardive dyskinesia with. She started on a trial. Her practitioner put her on one of the newer meds this summer after her twitches developed into esophageal spasms. So who saw that coming? It doesn't happen very often, but it happens. So because this new med was out there, she's on it, and her story is, my life changed. I didn't know how much it would change with antipsychotics. I didn't know how much it would change now that I don't have the twitches and the tics and the other spasms, but the only reason she was put on it was because she couldn't breathe. So again, that just kind of gets to, how do you pick who goes on it, who doesn't, when in every sense of the word, she would have been non-traditional.
So, Daniel, back to you.
So I'm trying to think of a way of answering this that relates to the other things I do. Parkinson's disease is by far the most common condition I treat, and I see many patients newly diagnosed with symptoms that don't need to be treated. We call that symptomatic treatment. The only treatments we have in that disorder are symptomatic. There's a vision that there may be more than that coming down the road, but right now it's treating symptoms. Symptoms don't bother you, we'll wait till they get worse. And in PD, they will get worse. TD is a little bit different. I think the twitching fingers you mentioned before, I certainly wouldn't treat unless it was interfering with typing or writing, and that was their job. And the difference is that there is really not much evidence that tardive dyskinesia is a progressive disorder once you've developed it, once it's become symptomatic. There were some old studies done years ago looking at people after 5 years out from treatment, and there was really very little change other than changes produced by various medications they had been put on at one time or another. But the clinical course, if you strip away the medicines, is pretty flat, or maybe even gradually gets better if they're off the neuroleptic, but at least pretty flat. So there's no risk of saying, "Ooh, I better treat this now because if I don't, it's going to get worse." That's a non-issue in this condition. So you treat based on intensity of symptoms and making patients more comfortable. That's what we do in Parkinson's disease.
Quick question for the manufacturers. Either one of you can jump in on this, but I know you have in your mind the real world and what is maybe likely to happen as far as uptake of these drugs, and I know your job isn't to estimate that or to share it necessarily with us if it is your job. But from a conceptual perspective, what you could hear from clinical experts and from maybe some patient groups is, every patient, somewhere between 300 to 500,000 in the U.S., deserves a trial of these drugs. Would that kind of be your view of the ideal uptake? Would be patients getting a shot with that being the population range?
It absolutely would for our shareholders, but I don't think it's a realistic vantage point for any manufacturer. I'm again going to back into the response of this. ICER is very well aware of our Reconnect study. That way, I think is going to be able to fill in a lot of the gaps for that. Those of you who don't know, our Reconnect study is a naturalistic symptom screening study in outpatient psychiatry offices. We've asked the next 30 patients that walk through your door who are chronically taking an antipsychotic, evaluate them. We have each of them, regardless of symptomatology, taking an EQ-5D, and Doctor, what you had asked for, there's a measure called the Sheehan Disability Scale, which asks those 3 questions. Does your health status prevent you from schoolwork, socialization? Any and all the above. For those who are quote-unquote symptomatic, we are then following for a year, and we will see how that changes. Does it progress? I think the body of evidence on progression isn't as
concrete as stated. You're hearing over and over again, a small study of X, or we don't know, or we're hypothesizing. So I think in a very short time we'll have a much better feel for that. We'll have a much better feel for why they're prescribing. But hopefully you've gotten a very good feel based on, I don't want to speak for Teva, but we have somewhat similar distribution methods. And even that self-selects many patients out who just simply don't want to answer the phone or receive the package or whatever. So those aren't, the usual fears of the payer is you're not paying for drugs that are being filled for years and years and years and aren't being taken. They're just flat out not being filled because there's no connection with that. So hopefully that at least fills in some of the gaps on appropriateness.
Yeah, and I was going to say, too, we did a health economic study looking at the epidemiology of tardive dyskinesia, and it was much less than, I think, the quota number of 500,000. But, in our clinical studies, we looked at what's considered to be greater than or equal to 6 on the AIM score, which was, again, considered to be moderate to severe. But what we don't know are those patients, and I think it was brought up earlier, that if you have a mild, let's say a 4, but it's all in your facial or perioral area, we don't know what the impact is. And if the patient is aware of it, and if it's affecting the work, then that would also be somebody that probably would be appropriate patient for that.
Okay. One last sort of unrepresented group. You brought up Medicare. How would you evaluate appropriateness in long-term care setting where antipsychotics are rampant? Might be an exaggeration, but they are highly used. Those patients may not have awareness. There may not be any burden, but because of their symptomatology, they're chewing through the inside of their cheek and now have to use a G-tube or some other form of, caloric intake. Whether, they're not asking for it, but just for the state of their health, this is an individual that should be treated.
All right. So thanks. So we'll circle back not too long from now on to the kind of cost-price issue as it kind of relates to the utilization too. But to keep building on this platform of a potential kind of how we translate this through into insurance coverage, now I want to come to the tetrabenazine question and other factors of a coverage policy. Barbara, do you just want to share with people now, not just from Harvard Pilgrim, but you talk to other insurers, what's coverage look like out there right now in this? How much step therapy, what's going on?
So I think
can you pull that just a little bit closer?
First thing to get off the table is I don't think that the AIMS scale is applicable to policy guidelines like this for all the reasons that you stated before. So we're somewhat stuck with the attestation that it's moderate to severe TD based on the provider attestation. So that is definitely our approach. We do require specialist utilization, which would include psychiatrists, neurologists, or any movement disorder specialists. So I think doing that somewhat self-limits the prescribing to the appropriate patient. I think additionally, there's a history of an offending medication, I think is important just to be sure as a diagnosis. Age, obviously over 18, where that's the appropriate treatment population, and also just that there's some type of persistency to the symptoms. And I've seen anything from 8 weeks to 6 months required as far as persistency of symptoms. So that's really, and the tetrabenazine question comes in a lot, and I think that's about a 50-50 as to what I've seen as to whether or not you require a trial with tetrabenazine.
Right. So whether what?
If you require a trial with tetrabenazine first, so you'd have to step through tetrabenazine before you can get either of the 2 new ones. Yeah. And historically speaking, our experience is that tetrabenazine is about half the cost of the newer agents. So I know there was some question about that.
Yeah,
earlier,
we're definitely going to get to that too. So this is one of the classic situations where insurers are varying. I'm sure the manufacturers know this landscape very well. So let's talk about, the possibility that insurers would interpret this and say, why not try? You already made one comment about this. Why not try something cheaper that might be as effective? We don't know yet. Has the same mechanism of action. I'm doing the devil's advocate here. Why not request treatment with tetrabenazine? Or if you look at the American Academy of Neurology guidelines, there are some drugs with even higher levels of evidence. Is it clonazepam, I think, has a level C?
Ginkgo biloba.
Ginkgo biloba, right. I'm sure marijuana will be there at some point, right? So,
Oh my gosh.
so we've got list price around $70,000 to $80,000. We've got a generic tetrabenazine that's now around $20,000 and change. So talk about the clinical appropriateness from the evidence of something else first. And if that doesn't work, then one of these new guys. What do you think? From a clinical expert perspective, what would the pros and cons be of that kind of approach? Oliver, you want to restate your concern?
I can kind of rephrase what I said, or simply just repeat verbatim, if I remember.
Well, I can do it.
No, it is, and I'm actually a great example, I believe you. Yeah. I work in an academic setting. I'm supposed to be an expert. How many times have I used tetrabenazine? Handful, maybe, in 20 years. I always send them to neurology because it is a drug that I feel, right or wrong. I use clozapine, so a very difficult drug to use. But I don't have the experience with tetrabenazine, and neither have any of my colleagues in psychiatry. I mean, there might be a few, but in the end, it is perceived in psychiatry as really a specialty drug from neurology. And I do believe that puts the hurdle so high. How would psychiatrists all of a sudden become experts in tetrabenazine in order to then use valbenazine or tetrabenazine? Maybe it's going to happen, but in the real world, it's hard for me to actually see that.
And just so we all learn, you mentioned that tetrabenazine is known as a difficult drug to manage.
Difficult. It's there's all these myths, what it can do in terms of extrapyramidal side effects, suicidality, orthostatic hypotension. It's not myths. I mean, these are all real side effects. 4 times a day dosing, 3-4 times a day, and so it is clearly most psychiatrists I teach, in a residency program and have a fellowship. Most psychiatrists are not trained in the use of tetrabenazine, so we would have to really re-educate, I think, a whole generation of physicians to be able to have this first step, to then use the drug. That I thought was actually the advantage of the new drug, that there is something that could be used and as simple as almost, valbenazine, actually not sure about the most recent labeling, but that the starting dose is actually already the effective dose. There's nothing better in medicine than, when the starting dose is the effective dose, 1 pill a day.
Yeah. Daniel, I'm sure you have.
The reason, I think, just to complete your thought, Oliver, is that psychiatrists, pass it off to neurologists is because of the side effects of tetrabenazine include Parkinsonism, akathisia, and depression, big time. Depression, the psychiatrists can handle. Akathisia, maybe they can handle because they've seen it in their own patients from neuroleptic drugs. Parkinsonism, I don't think they want any part of that. It's too complicated. And some of these people turn out to have Parkinson's disease that's been unmasked by the use. So that's the complicated part. The question is, can you, with the side effect profile being limited, the major side effects seem to be somnolence, headache, I think, fatigability, and akathisia in one of the 2 drugs, and I never can remember which one akathisia came up. So that's sort of easier, I think. Correct me if I'm wrong, for a psychiatrist to get his head around and not require so much worry about what bad things can happen. Having said that, I've seen, this is off the record, 2 patients developed drug-induced Parkinsonism on valbenazine, and I've only been using this for a few months, and I haven't treated that many people. So that's 2 already. I don't know what the denominator is of that, but it's... so it can occur. Just because it didn't in the trials doesn't mean it can't occur out in the real world.
Right. I just wonder, Barbara or Paul, do either of you tell us how insurers sometimes think about the devil we know and the devil we don't? I mean, so tetrabenazine has a black box. It's been in use for 30 years? So it's been out there.
Europe, yeah.
Well, Europe, yeah.
The newer drugs, short term, seem to offer fewer side effects. Maybe we'll start to hear more studies, or more, either anecdotes or data on other things. From an insurance coverage perspective, how does that factor into what you do in thinking about step therapy? Would you, again, put yourself inside the heads of insurers who are just choosing whether to do tetrabenazine before coverage for valbenazine, or even something else like clonazepam or something else. How does the unknown or the less data on long-term risks play into that scenario?
I'll take a first crack at it.
Okay.
So tetrabenazine, although it's been around for a long time, has, as you've demonstrated, somewhat limited evidence for its efficacy for the treatment of TD. So that already colors the question. But we also have the guidelines that were established by a deliberative body that has other agents in front of tetrabenazine as a preferred choice for the treatment of TD. So I think we certainly contemplated whether, when these new drugs came to market, whether we should use a step therapy approach. And with early consideration, some of our draft guidelines had just that, but then we modified those after deliberation and consideration. So I think that to a certain extent, I hope that payers and insurance companies behave like clinicians. When a policy is contemplated and implemented, that it be considered a first try. So every therapeutic experiment is just that. You don't know whether the patient will respond or respond as expected. So as we launched our initiatives in our policies around VMATs, we are rapidly assessing what happened with those policies, and we've already adjusted them several times and even though those drugs are very new to market. So today, we do not require a step through tetrabenazine for either Austedo or Ingrezza. Both of those require prior authorization, as many of our drugs do, but the threshold for approval is relatively straightforward, and we do not use patient-specific objective or measured outcomes. We use descriptive terminology such as persistent intrusive TD, for example, adult age. And we can manage the overall process of how we want to use this particular category of drugs through the duration of the prior authorization. So like a clinician that is attempting a clinical trial of a drug in a patient, we can anticipate that if we receive a prior authorization request and we approve it, that if we get another one, whatever threshold we put there, 3, 6, 12 months later, and we get a request to continue the therapy, then there's a reasonably high likelihood that the clinician and the patient are satisfied with the use of the drug. And that kind of works pretty well. And we can watch the drop-off based on the persistence with therapy in our claims data. So we learn from that process. We also have, I won't get into the cost issue because I don't know if you're going to bring that up another time, but I'll stop at that point. So we do not require that. The last time I had the benefit of sitting on one of these roundtables, I'll say right now what I said then is many payers, and we certainly find the guidelines of deliberative professional societies to be very useful in our deliberations on where these drugs belong in therapy. And some such societies or organizations are very responsive to new-to-market drugs, and some not so much. It would be very beneficial to the payer community to have AAN refresh their guidelines. We're expected to respond essentially immediately, or yesterday, yet we wait for 3 or 7, 4, 8, whatever the number of years are for these guidelines to be updated. That's not an acceptable position from my perspective, because we do depend on that.
Barbara, thank you. Thanks. Paul, did you want to add anything?
Yeah, I think we pretty much take the same approach. And just to narrow it down to your initial question, we do take side effects and potential downstream effects into account for sure. It's always considered. And I think it's still being deliberated at our organization regarding the tetrabenazine. And again, to stay away from cost. If all things were equal, it would be a different discussion.
Right. Okay. A couple other things before we start to talk about cost. It's always, I want to jump there too in some ways, but other aspects of the coverage policy and also from clinical practice. We haven't talked much about the switching or reducing dosing issue again. So think about it from an insurance company perspective. Would you want an insurer to at least ask the prescribing doctor whether they have tried to switch drugs? Are there any Like, let's say it's an affective disorder and it's Abilify. Is there any reason for there to be a loop back to say, did you consider changing the drug to get rid of the condition before prescribing this new drug that may have side effects, et cetera? What about that clinical loop?
I wouldn't go there with a 10-foot pole. I don't think the insurers should be getting into the finer points of managing patients. There's many different ways of managing these conditions as there are patients, and to ask them to say, well, did you try this? Did you try? Where's the limit? Where are you going to stop? Did you try clonazepam yet? I think they usually limit themselves to other drugs of the same class that are usually cheaper or generically available. But to get into the finer points of management,
Although I was impressed by the patient-generated data. That I forget what % it was of patients who'd had their drug changed, and their symptoms went away. Now, maybe that means that their psychosis or their affective disorder is off the charts, or who knows what. But I was struck by, from a clinical perspective, the instinct, don't we want to somehow create a policy structure that incentivizes doctors to at least consider switching drugs before prescribing another, drug with again?
I think since the insurers do look at evidence-based medicine, even though I said that's something I do, I'm not sure I could marshal a lot of convincing evidence-based medicine to support what I said. So that was expert opinions. They used that term before. So I think that's shaky. I don't think that would work.
I think in the ideal world, I would like every psychiatrist to be practicing evidence-based and competently, and I would like our professional organizations to actually have guidelines that are 2017 or 2018, and not 2004 or something. I think it's a huge issue. So in a way, while I agree in philosophy what you're saying, it should be the clinicians who are making these decisions. I actually think, if an insurer in the end plays a little bit devil's advocate, well, did you even consider, some things that guidelines ought to actually recommend, like switching, or, is it really absolutely necessary for this person to be on this drug? Because no one else is going to do it. I actually can live with that as a kind of a quality assurance piece.
Mm-hmm. Insurers, what do you think of the administrative burden or just the clinical sense of querying the prescribing doctor about the prescribed drug that is? I'll paint the dark side. The dark side would be doctors now, maybe who don't have that much experience with TD, but who are prescribing antipsychotics. Maybe they think, ooh, there's something that takes care of TD now, so I can expand the use of antipsychotics in the kind of gray zones where I wasn't prescribing it as much because of a concern about TD. Maybe I'll just prescribe more of it. I think that was your point. And maybe we will trigger more TD that way. So that was my question. So I guess I'll circle it back to the insurers. Do you think insurers, you or others, will consider some kind of ask back about the switching or changing drugs?
I'll take a swipe at that.
Sure.
I think that's fair game. We would make a threshold kind of decision on that, though, about whether we thought that was an appropriate intervention in the particular circumstances. I would like to believe that most prescribing is evidence-based, but I actually know that not to be true based on the evidence that I can develop reams of. So there's a reason for a gut check, and I'm not trying to be disparaging, but it is a reality. And we often defer, many insurers do, and Barbara just described her policy around deferring to a specialist for prescribing purposes, and that usually raises the bar a degree, although it's not an absolute. I can tell you I have experience with specialists that are not using evidence-based medicine practices. So we could defer that decision. There are times, and we certainly do that with certain therapeutic categories. Again, this is the threshold question. Will we see enough patients? Are the costs high? Is the risk high? Where we might add that kind of a criteria. Have you contemplated doing this rather than that? As opposed to just give us the evidence that you've done these three things. And sometimes we do that with a direct outbound call to the clinician. We got your request. It's not approvable as it is, or it's potentially approvable. Have you considered doing this other thing, which in this case could be, not that we would do this, not that we do this, but have you considered changing the offending agent? That kind of a concept in the care of patients is a dominant concept, right? You remove the offending cause of the condition or the symptom, if you're able to do that. Again, for us, it's a threshold kind of question whether we're going to do that or not.
Daniel.
In response to that, I can count on the fingers of one finger how often I get calls from a physician who is employed by the insurance company to ask me questions of, would you do this? And very often it's an obstetrician or a pediatrician who confesses right away, I don't know anything about neurology, but nonetheless I feel compelled to ask you this question. Most of the time the prior authorization is a very set piece of bureaucratic paperwork, which is either responded to yay or nay. And there's very little interest in inquiring of me, even though I've said it in my letter, what my rationale is of exploring that. So, maybe ideally that would be a great thing to happen, but I don't know if you have the manpower to do that for many medicines. Actually have a phone call with somebody.
Just a quick comment on that, and so again, that to me is the threshold question. So if it's a large enough population and not large enough spend, a large enough concern for misadventures of one stripe or another, where we might do that. And it might be that some of those calls come into your office and don't get to you. So I don't know what your office practice is like, but we know that many practices today have personnel dedicated to managing the prior authorization.
I wish we did. We don't.
So that question may be coming in and may be dealt with by somebody else on the staff. So let me stop there.
Yeah.
I don't know, Barbara.
I think it's valuable among the many good points. There is obviously a trade-off to that kind of decision, right? I mean, there's an administrative burden for the payer. There's a relationship burden in the relationship with the prescribing doctors, because any system like that is going to find more clinicians who are probably not happy getting the call than clinicians who are going to change their decision because they've just been, shown that they have an opportunity to practice better medicine. So making that judgment and how that balances out is challenging. But anyway, I thought it'd be interesting to raise as a possibility. Terry?
And there's a person on the receiving end. The odds are that the person who has developed the tardive dyskinesia now has been on multiple antipsychotics already before they landed on the one they're on now. So from a person's perspective, and I'm married to a psychiatrist, so I understand all of these pieces and the necessity that many places have had to hire people who deal with the payers. That's the necessary evil in which we live. But in an illness state where it honestly is still as much about art as it is about science, because it's so individualized right now without the biomarkers that other illness states have, to add that extra layer. And if I'm the individual or the family member who is told there's this great new med out there, but we need to put you on this one that has a black box warning, et cetera, before we can try you on the one that is the safest and the most likely to work. Oh, and he's going to have to take it 4 times a day. There's a person on the receiving end.
Right. Yeah. That's back to the tetrabenazine issue, which is intriguing when you frame it that way. Absolutely. Last small piece before we talk about pricing and other aspects of how we can pay for these drugs. Stopping rules, which are becoming an increasing thought process for coverage, which means some attempt at using the drug is done, and we either query the clinician or have some limited prescription, after which the doctor has to document that the patient's getting better. And if not, then maybe it's an appropriate time to either switch medications or just to stop. Stopping rules on this kind of drug, would you guys think it's part and parcel of what you'll do?
It definitely is. And I think that historically it's always been a 12-month approval frame, and that definitely is trending to a shorter approval frame. In this space, it would be closer to 6 months, and that, again, is just to force the check-in and to ask the questions, are there symptoms improving? Has their work life improved? Has their social, any improvement? So again, it's just attestation, but we're asking the questions just to force the discussion from the provider and patient. And it's 6 months for us currently.
Okay.
Paul?
I'd have to call in a lifeline. Kim, is ours?
I'd say very similar to Barbara's.
Oh, okay,
yeah, attestation with short.
Oh, yeah, but is it 6 months or are we 12? Most of ours are 12 months, and we make a determination whether it would be shorter. You think this is 12?
12 is definitely the standard
Yeah.
in the
Yeah.
marketplace is 12 months. On certain drugs that are higher cost, we've been doing a shorter time frame, and we actually do the reviews internally so we can see what's going on. So it's 6 months originally. We'll probably bump it up in time, but.
Okay. So let's talk turkey. It's after Thanksgiving. Do formularies need both of these drugs? Do patients, clinicians need the choice? Is if the best way to achieve efficiency in the health system is to negotiate, use the free market power to get a lower price, should a payer say, well, boy, these two drugs even sound the same. They've got the same mechanism of action. Why don't I negotiate them head to head? Offer one 100% of my business, and I'll get the best price for me and my patients. Yes or no?
I say we go for it. We haven't gone for it, but it would be it's a consideration for sure. In your assessment that I was able to observe here, I think that if I remember the voting correctly, the panel was unable to distinguish a benefit between the two products. So that becomes a very important threshold for a competitive bid. If the side effect profile likewise pans out to be indistinguishable, and in the absence of a very definitive protocol for initiating therapy that would lead one to choose one over the other for some other reason, then that's a perfect example for competition.
Barbara, any different considerations?
No, I have to agree with that. I think that given the fact that there are so many equalities to the two drugs, I think that choosing one of the over the other may be the only way that it becomes cost effective for us or any way affordable. I think it's important to note too, though, that time is really going to tell about the interchangeability of the two, or if one becomes favored over the other. And just looking at our experience with these drugs, which is very small, we've had 6 members on them. 2 of the 6 have switched already from one to the other. So don't know why. Didn't have the time to look into that, but I think it is interesting to note that there's already some switching between drugs. So that may come into play in our being able to choose one over the other.
And manufacturers, you may have some opinion on this question. So I'm sure it would be fine if it's your drug that's the 100%, and maybe you feel like it should be. But in principle, what would you say should be some of the considerations you would want payers, and I'll turn to the clinical experts and others as well, but from your perspective, how would you want this question to be thought about?
I don't think it's anything that's earth-shattering. You guys have already discussed it. Other members of the panel have talked about ease of use, tolerability, access, affordability. That being said, the end consumer for valbenazine patients, average out-of-pocket is less than $10. So that is not a consideration for them, per se. So then it would fall back into really the body of evidence. But the fact that we're still debating the body of evidence for tetrabenazine is also unsettling. So I get it.
Okay. Victor, any thoughts?
Yeah, I don't have much to say on this. This is a competitive market, obviously, and our market access team, works with the payers. I'm on the medical side, so I don't see that much visibility.
All right, thank you. Clinical experts, if you had to guess, both from your own experience and those of your colleagues kind of in the community, would they erupt in righteous indignation if only one of these drugs were made available on their formulary?
It wouldn't bother me that much, but I think it's not unusual practice for a clinician to use a drug for something, and then if it doesn't work, use another drug. Even in cases where it's sort of almost irrational because the other drug is so much like the first one. What's the reason? We have this in Parkinson's. There are several drugs that all do the same thing, and I don't go jumping around from one to the other. I just give up. But many clinicians will do that. They'll go through A, B, C, and D until they find something that works, or they are satisfied that nothing works.
Interesting. Oliver, what do you think?
Well, there are, not to pit these drugs against each other would need head-to-head comparison, many patients, longer period of time. It's never going to be done. But they are technically slightly different. Valbenazine is a prodrug, and if you look at the metabolites, it only really produces one of the metabolites, which is presumably the more important active one. The other one, the deutetrabenazine, is basically a tetrabenazine with the exception of the pharmacokinetic properties in that it just prolongs the half-life. It still has, unless I'm mistaken, the same kind of profile of all the metabolites. These are actually very complicated drugs, so I think there's a little bit this phenomenon that they look similar or even identical at some measure, but then if you actually start treating patients, you might find out that patient A actually does better with drug B and vice versa, and you switch. So in a way, I am for the having the choice between at least 2 drugs maybe, or 3, but at some point to cap it and stop the Me Too drugs,
Interesting.
Yeah.
And just to be clear from the insurance perspective, if you compete that way in offering one drug, if you will, full exposure, whatever you would call it, the other drug is available on appeal if the one drug doesn't work, or how would it work for a clinician and a patient?
That's how it would work for us. So it would just be a preferred. So we ask you to try the preferred drug first, or give us some reason why the preferred drug's not an option, and then you can get the non-preferred. Pretty simple.
That would be the common practice. There is a nuclear option, where it's not on the formulary. Tough noogies, figure it out. But that's not typically exercised by insurers, nor is it necessarily in everybody's best interest. There could be a circumstance where that might be appropriate, but not in this particular circumstance.
And we also try to employ cost or copay differentials, but often those efforts are thwarted by other efforts by manufacturers to
the copay coupon.
The copay coupon.
Yeah, absolutely. So as we start to talk more specifically about cost and price, I'm kind of curious from the patient perspective. We heard, what Charles said was the average out-of-pocket has been low so far, I guess. Do you guys hear anything from the patient community about concerns about the impact on the finances of individual patients for treatment for tardive dyskinesia?
I have a case study of one, and it's the individual who submitted her story, and the cost was going to be $64,000 for the year. There was one pharmacy in her area who would mail order it. It wasn't something they stocked, so they had to make special arrangements for the pharmacy to get it. And whichever medication it was, and I honestly don't remember which of the 2 it was, the company gave her some kind of she qualified for some kind of drug assistance, and she wasn't going to have any out-of-pocket.
Really, the only people I've come in contact with who tried this have been in the clinical trial, so nobody yet who's has a cost incurred.
I don't keep close track of it, and I should have, but I don't. But I have several patients with xenazine, tetrabenazine, who don't pay for it or pay a pittance for it, very small amount. I don't know, do they submit their income tax forms? I don't know how this happens. But the deal with the insurer didn't work out good enough for them to be able to get a lower rate, and they wound up getting supported by the company that makes xenazine. I think the company's motivated to get the drug out there as much as possible, expand experience with it, so there's something in their favor of just getting it used, even if they don't get paid for it in some cases.
Okay. All right. So I want to invite the CEPAC to raise your tent card on its edge, if you will. If you've got questions or comments to make, I'm going to start to go into the price cost issues, and I'll circle back to you. So I think, sometimes we end up with drugs that are, the list price that comes from the manufacturer. Sometimes it really is hard to discern where that number comes from. But I think I know what happened here. What happened here is that companies saw an unmet clinical need being treated by an off-label drug that had been approved for an orphan condition, Huntington's chorea. And as we all know, drugs for orphan drugs or orphan conditions traditionally have high list prices at least. So looking at the landscape from the manufacturer perspective, you've got unmet clinical need, a drug being used off-label that costs around $80,000 per year list price. Okay. And you're creating a drug with better evidence, and you can price it around list price, around $70, $75, and actually look cheaper than the off-label use of this other drug. On the other hand, it's kind of been an around-the-horn approach to kind of judging what to benchmark the price to. And so we march in with our cost-effectiveness modeling and say, how much better does it improve patient lives and measuring the quality? And we come up with this shockingly low to where it's been price. Remembering that this price, in a sense, again, was kind of tethered to a rare drug for an off-label use. So it feels like we have a structure in which the competitive landscape called for the innovation that we've now got to a certain extent and hopefully continue to get. But it's been crosswalked from a price that creates, a $70,000-ish per year treatment for a pretty prevalent condition. If we really do want to give most patients a shot at this, we're talking about billions of dollars a year at that price. So the question is, what do we do about this? Is there something about indication-specific pricing here? For instance, I know these drugs are getting labeled in other conditions. Tourette, which one of your drugs is Tourette's also? Is it?
They're both in development.
Both in development. Oh, I thought you already had.
No, no approval.
So don't worry about that. One of you has another condition, doesn't it, at this point? Huntington's, okay. So let's imagine a world in which you would want to or be able to price differently for these different conditions. Is that something that's on the table in your companies? We're hearing about it. CAR T drugs are being talked about, indication-specific pricing. It's been, especially when we've got drugs that may be effective for a very small population, but then again get kind of credentialed for a much broader population. It feels like the system is going to sink if we keep those very high prices for those ultra-rare indications and just spread them across the landscape. So you guys aren't here to talk from your company's perspective about a lot of things having to do with pricing, I recognize. But if you can comment, is that a fair picture of what happened with the pricing in terms of how your companies viewed the landscape and the way that when you see with current treatment, as good as it is around $80,000 per year, does it not create a difficult impetus for your own pricing to come in around that level?
It does, and to be fair, during our pricing research, during our development program, tetrabenazine was accessible in about every single plan that we evaluated with just a simple checkbox for the indication. And it was actually north of $120,000 that was being charged at the time. So again, our philosophy was by far best drug, best price. You brought up, did you think about indications? Absolutely. As we move forward with our developmental project, we're constantly researching what would be a viable pricing for that. So it always comes into play, but your scenario is very much accurate in that, and moving forward. But so much of it, we haven't brought up other alternate therapies. Deep brain stimulation is covered or was covered, with a checkbox. So there were some pretty wild things available out there, but that's an indicator of unmet need. Versus affordability, and in our vantage point, single daily, very effective, very well tolerated, at the lowest price was something we thought would be at least a foot in the door.
Okay, that's very fair. Victor, anything to
I
add?
to be honest, I don't know the answer to that question. I know on the medical side, what we try to do is look at the drug as a standalone entity and try to produce a value proposition based on that. And then we did actually do an indirect treatment comparison to tetrabenazine on the Huntington side. But unfortunately, I wasn't in the conversations about how the business side actually priced it. We just supported the drug, and then we collaborated on producing some of the data for the medication.
Right. Because it just strikes me, and again, the psychology of this is hard to pass up. again, as you pointed out, when the landscape says 80 or 120,000 is being approved by the insurers, and you're coming in with a better deal, isn't that a better deal? On the other hand, this is part of the inefficiency of any health system. From our perspective, to a certain extent, if you go by the evidence as the cost effectiveness spits it out, these drugs are priced far higher in proportion to their added benefit to patients than drugs for many other conditions.
But in fairness, based on currently available data.
True, but it's hard to imagine, given the sensitivity analyses, that the data could be so much better that it would bring the price. And it feels like that's because you're tethered to this rare condition price that got crosswalked in to a prevalent condition, and that if we could have broken the chain there, we'd be in a different, if someone had said, wait, if we're going to use tetrabenazine off-label for a prevalent condition, if we had the wherewithal, we could have said at that point, tetrabenazine shouldn't cost the same for treating tardive dyskinesia as it does for treating Huntington's. We don't have that switch in our system, but it's being talked about, trying to figure out indication-specific arrangements, et cetera. It feels like we're building a box, because we asked earlier, again, how many patients are we talking about would we want to treat? I can't do the math quickly in my head, but I know that in our report it says that at the estimated net price, which would be a 27% discount off of list, only about 15 to 20% of eligible patients would be treated before we'd get up to around $1 billion a year. So imagine treating 50% of patients, or 75%, where the clinicians would like to take us and the patients and their families would like to go. We're talking billions and billions of dollars per year to treat, unfortunately, a condition that's been caused by other drugs that patients take. So it feels like we're building ourselves a very top-heavy house of cards. Any solutions on the table? Payers? How are you going to help try to get
We're going to rely on people like you, Steve.
I'm sorry.
That's something that we are constantly faced with. We have to practice population medicine. We have a fiduciary responsibility to our entire membership. We want to do what's best for all of the people that have horrible diseases and orphan diseases, but unfortunately we need to treat the other people as well. So it's a constant balancing act for us. It keeps us up at night. I don't think we have a solution. I certainly wouldn't be sitting here. I'd probably be in the beaches of Bora Bora vacationing if I had an answer to that, Steve. So I really don't know.
Paul, you represent the public.
And thank you for paying me to be here today. You started with the indication-based pricing concept, and then you later used the comment about making a pricing arrangement. So let me just latch on to a couple of things here. So you may notice a little bit of gray. I've been around a long time. With rare exception, I have not seen a branded pharmaceutical reduce its price. There have been a couple of exceptional circumstances, but it doesn't usually go that way. So I wonder how a indication-based pricing would be dealt with by the manufacturer. It would highly likely be through a contractual relationship with a payer. Is that really where we want to go with this? Just saying, it might well be. And to Barbara's point, trying to manage the many different pricing algorithms that could be available to a payer becomes an exceedingly challenging and burdensome process for the insurer. So Barbara used the phrase fiduciary responsibility. Certainly we have that responsibility, but constructing a universally flexible pricing schema for any organization, whether it be the manufacturer that brings us these products or the payer, or to try to embed that concept into the prescriber or patient, it to me seems to be not the way to go, because sometimes at some point that collapses under its own weight. So I don't have the answer, I don't think anybody does now, but it is certainly one of the top questions we have in healthcare today is how are we going to support the development and access of ever better drugs for our patients so they get better. And I have thoughts, as many of us do, and will the competitive marketplace be the answer to that? Perhaps that will be helpful. But if the starting point, let's say the ICER evaluation is perfectly accurate and these drugs are wildly overpriced, in our best case scenario, we might get these prices down by 50%. We're not going to get them down by 75 or 80% through a negotiation strategy. So we're going to be left holding the bag a little bit here. Somebody will be. And ultimately, of course, it is the patient. Patient pays one way or the other somewhere along the way through taxes, through insurance premiums, through co-insurances, through co-pays that may or may not be modified or mitigated by a coupon from the manufacturer, things like that. But the system is bearing the weight of all of this. We have a pricing dilemma. I don't have the answer. But we will be entertaining in a much more aggressive way in our program than we have historically about trying to structure a whole new way of thinking about the way we pay for pharmaceuticals.
Great, thanks. So one last question for me before I turn to Stephanie and others, and we'll circle back around too. But let's say a little bit about what we anticipate should be the best way to translate this evidence into the coverage that relates to out-of-pocket payments. Now, I know employers have different, obviously plans, et cetera, but there are some principles around this because, sometimes the tiering and the differential out-of-pockets is paid to really drive patients toward generics as opposed to brands, et cetera. Are there any specific thoughts about this patient population, this set of drugs, and good principles to abide by in setting up the out-of-pocket arrangements for patients? And I'll certainly come to the patients to see if they have some thoughts. But from your guys' perspectives, how have you thought, or how do you think insurers should be thinking that through?
I have to defer to Barbara on
I know
that one.
you don't have
for me,
a lot
but
of flexibility.
Yeah.
Barbara, what do you
So
think?
from a commercial payer standpoint, both of these products are still new, and we have not determined final tiering status. Being the eternal optimist and patient supporter that I am, despite being in managed care for almost 30 years, I do think that one of them needs to be in a preferred status to make it affordable to patients. Preferred branded status, obviously. Tetrabenazine is in a generic status for us, a generic tier.
Right.
I do think it's appropriate to have one of them preferred just to lower the patient cost burden. That would be my approach, not two, but one. As far as what cost shares are, that's so variable in the commercial marketplace now, and it's really set by employers. Mm-hmm. It can go anywhere at a preferred status from $25 to a 30% coinsurance. It's everywhere.
Okay, thanks.
And as far as coupons, we don't see the coupons because it happens post-adjudication, so we don't even know that's happening, which is probably a good thing.
It is happening. Terry or Patrick, any principles that you would want to put out, either kind of re-emphasizing that one or different?
I'm stuck in the answers that they just gave. It's such a complicated system, and we see everything all over the spectrum. There are going to be a large percentage of these folks who are on Medicaid, who fall into their own separate category. So then you're fighting these fights with state governments who determine what Medicaid does and doesn't pay for. There just have to be options, and it just needs to be accessible.
And basically, I agree. I mean, the biggest need probably is in Medicaid, and so you're going to have the states, approving it for their formulary, and I don't see how that's going to happen anytime soon at the base that we're at. I mean,
right. See, what's interesting to think, I don't know what, when you said Medicaid, for some reason it just triggered in my mind a completely unfair analogy. But after several years, the course of treatment within Medicaid to cure hepatitis C will be somewhere in the range of $15,000 to $20,000, and we'll be paying twice that for tardive dyskinesia for 1 year. So it's an interesting, again, That's, as I said, it's probably completely unfair, but it just struck me when you mentioned Medicaid. Because in the Medicaid budget, think about their use of resources.
Yeah, limited.
Hep C patients, 3 of them could be cured for the price of a year of tardive dyskinesia care.
And it's what people with mental illness have been fighting across the board for years, with access to medications to treat mental illness, not just the side effects.
Yeah. All right, I need to step down off that mini soapbox. Stephanie, what?
Thank you, and thank you all for that wonderful discussion. I learned a lot from everything that you all had to say. I had 2 things that I wanted to bring up. The first thing is, I just noticed, I don't know how I missed this before, but I just noticed that both these drugs have a risk of QT prolongation, and the FDA has a warning about that. Nearly all, if not all, antipsychotics also prolong the QT. And so I wondered, when these drugs are used in practice, if we're routinely monitoring EKGs and if that should be something that we should be doing if we're not doing currently. So that's my first question. And my second question. So I'm sure at least some of you are aware, probably Dr. Freudenreich in particular, polypharmacy is a huge issue in psychiatry. We now have antipsychotic polypharmacy as a term because we use multiple antipsychotics together even. We underutilize clozapine objectively. There's evidence that shows that we underutilize it in the U.S. versus Europe. And so I would think that one of the things that we could consider is focusing on increasing clozapine use by reducing barriers to that, rather than adding another drug to a patient's profile. So for example, having somebody on risperidone who develops tardive dyskinesia and then switching them over to, presuming they had tried another one before then, switching them over to clozapine. If they hadn't tried another antipsychotic before that, then perhaps quetiapine. That would be an example. So the patient would have one drug versus risperidone plus one of these 2 new agents. When we have 2 agents, we have 2 drugs with potential for drug-drug interactions, potential for additive adverse effects, additive QT prolongation. We also now have the risk of suicidality and depression, which in the short-term trials didn't have huge signals, but it's still something in the back of my mind. And finally, we know that clozapine, in contrast, actually reduces suicidality. So I wanted to put those 2 points out there and ask about EKG monitoring.
Just a point of fact, I think, correct me, the pharmaceutical folks, that valbenazine does not have a QT effect.
That is correct. There was absolutely no QT signal. That language that came into the label was independent modeling by the FDA based on nothing from any of our clinical trial data.
There was a pass-through from the tetrabenazine black box.
Okay.
As far as clozapine, I can tell you, interestingly, I was at a meeting recently. It was a course on movement disorders, and a bunch of psychiatrists, interestingly, attended from Canada, mostly from Ontario. And they use clozapine in enormous amounts there. One doctor said 50% of his patients are on clozapine. He doesn't deal with any of the blood tests and the pharmacy interaction with his office about they had their blood test and it was normal. They don't do any. It's all done for him. It's a Canadian system, so it's a different system. There's no question in this country many clinicians avoid clozapine because of the pain in the neck of prescribing it. But it's certainly a very valid option that's been underutilized, to answer that question.
Interesting.
And I was going to say, too, from a Teva standpoint on the QTC, Teva did actually an independent or a standalone QTC safety study, and it went to 24 milligrams. That's why in the label, after 24 milligrams, if you're on an antipsychotic, there is a suggestion or a recommendation by the FDA to check QTC.
Let me just get that straight. At 24 and above, or above 24?
Above 24.
Above 24, thank you.
Can I also confirm, this question came up way earlier, I should have thought earlier to have you guys confirm, the FDA has no requirements for you all to do follow-on studies after approval. Is that true?
We have reached all that commitment from a long-term standpoint. As I said, we've done our 3rd now observational study, all focusing on durability of effect, which you've all asked about. And the answer is, it is. We have seen no signal of lack of durability in that. And also within all of those, there haven't been any additional safety signals, if you will. Yeah, the others are, as the FDA often does, is suggestions.
Right.
And actually constantly deliberating that, what else we could do.
Okay. And do you guys have any ongoing?
Yeah, we have one post-approval study we need to do that's going to be part of our long-term study.
Did they identify the specific outcome they were interested in tracking?
They were looking for washout and persistency of effect after a washout time, which it could be anywhere between a week or 2 weeks. We're not sure yet.
Okay. All right. Interesting.
Actually, along those lines, and we'd love to turn this into an advisory board, the ask of the FDA of us was to do a study of the ability to go back to work, and we're still trying to figure out how to measure that. So any thoughts on that, please contact us.
All right. Good luck. Yeah, so we'll do a couple more questions.
Can I just actually thank you for bringing up clozapine? Totally unselfishly, I'm in charge of our clozapine program, which is over 200 patients at MGH, and I'm in part to blame because I do believe it is, other than the metabolic side effects, so there's a whole new group of other problems. But it is actually for the neurons, it's the safest drug that I believe we actually have. And I certainly, anytime I have an abnormal movement or where I get concerned about it, I offer switching them to clozapine. That's actually my first step. This is not an initial indication, but the idea of EPS sensitivity, and that includes tardive dyskinesia, I think it's very reasonable to propose this to patients. And it is unfortunate in this country that clozapine is hugely underutilized because it can be used, I think, could be used safely if we had a better healthcare system around it.
So it sounds like something that payers may want to consider as far as that information back to the prescribing doctors, some consideration of clozapine. Yes, Patrick.
I was involved in a project in Florida. The Florida Medicaid formulary includes clozapine, and they consider it the best treatment for people who have not reacted well to other treatments. The problem that they faced, and the reason why they came to us to talk about it, was the resistance of people to take it simply because of the fear of the blood tests and the possibilities, and that goes back, 25 years.
Some trade-offs. All right, a couple other questions. I think actually Jean was first.
So this has always been very informative, and I want to thank you all. But I want to raise our collective sites to a little bit higher policy level. That's kind of where I live, and the kind of micro policy of arranging co-payments or indication-based pricing. We just lost U.V. Reinhardt, who was one of my heroes in health economist, also because he was a very funny guy, and his one of his most famous papers was titled "It's the Price is Stupid." And I'm not calling us stupid, but if we the indications were that at $11,000 a year for one of the drugs, the qualities would have worked out fine, and we would not be here. And we have significant. We are a wealthy country. This is not a zero-sum game, but there are significant questions of resource use. Should we be investing these funds in getting better antipsychotics, for example, that don't cause TD? Should we be investing funds in better academic detailing for better evidence-based prescribing? So I guess my theoretical question, and I'm not putting the manufacturers on the spot, but if we could have restraint from the manufacturers at initial pricing, I look for policy levers all the time. Where is the best place to get the kind of policy output that we want? You look for clinical outputs, I look for policy outputs. That is a lever. The alternative is a regulatory hammer. And I think that is probably more, I guess my question of the panel and the payers in particular is, at what point do you stop trying to move the deck chairs on the Titanic and get some desired behaviors from patients or clinicians, and at what point does that regulatory hammer start to come down?
Easy question.
So there's not going to be a really good answer to that. A lot of experimentation going on out there. Massachusetts has requested a waiver from CMS to operate a closed formulary in the Medicaid program. That is groundbreaking, and that's a hammer. I don't know if it would be the solution to the problem, but we feel kind of compressed into reaching for all the levers that we can identify to modify policy. The point you made, though, is beyond the grasp of a state Medicaid program, and you're talking about the launch price of a product. And that seems to be the most elusive part of this whole equation. Tip of the hat to ICER to trying to get it, but it's, the methodologies we're speaking about now are all in response and reaction to that launch price. And that, to me, is the Achilles heel of all this other stuff we do. Whether the hammer is a 16-ounce hammer or a sledgehammer, we're still going to have to deal with that problem or that issue. I don't know if it's always a problem, but it's certainly an issue.
I'll just quickly throw in, because I want to let Terry make a comment before she leaves, that we probably would still be here, but we would be here to rain confetti down upon the head of the innovators who've shown true social solidarity in responsible pricing. And so that's the future that we might anticipate if we get lucky. On the other hand, Terry needs to leave for the airport, so what I was going to do is please I was going to say, in one sentence, what would you want to make sure that we capture as a take-home message in our report? Frequently, I encourage people to think of what's the one thing that you would want one of the people at this table to do with the evidence as we've discussed it today that would make the world better from your perspective.
No pressure there at all, since my car is waiting outside the door. I want people to have options, and I just want everybody at the table to keep that in mind from a payer's perspective, from the industry perspective, and from the clinician's perspective. But I do have to add this. NAMI is convening a group for the third time to come up, hopefully, with a white paper to encourage discovery and to focus on the issue that you brought up, that we really do need better treatments, and we've got to have better science to get the treatments. And we have a commitment from Josh Gordon at NIMH to join us in March when we get the next group together here in Boston. So fingers crossed.
Right, and thank you for coming. Thank you very much. All right, so for the policy roundtable, again, now you've had the chance to panic and think quickly about your sentence. But please frame it any way you want, but feel free to ask things of others. What would the actions be, and from whom that you would love to see to make this treatment area for patients and for the system to be in a better place in 5 to 10 years? Patrick, we'll start with you.
I think, from the point of view of people living with TD, we want to see both of these available, both of the new two available, and we want them to be available in a way that we can access them. Particularly, most of the people I work with are people through community mental health, public mental health, and most of the people who are living with TD through our surveys are people living on SSI and Medicaid. So it has to be able to be accessible through Medicaid.
All right, thank you. Daniel.
I'll pass for a moment and circle back to me.
I'll allow it.
Yeah.
I feel like the judge.
From a distributive justice perspective, it's kind of, I wasn't born in this country, and there's many strengths to our system, but also many weaknesses. It always strikes me, and like we discussed a little bit, this an absurd discussion. Shouldn't say that in such stark terms, but there is actually, I think it is a possibility for a better medicine that we have, and yet it seems to be priced at a level that the way the healthcare system is structured, that the patients who need it the most and can afford it the least are probably not going to get it. And again, I don't want to pitch any group against any other. I think hepatitis C, I worked in an HIV clinic, was actually huge, the impact that a curative treatment had there. So these are tough decisions, but I think in the end it's what you brought up. It is something that is a much higher discussion than we fiddle. Once the price was set, now we try to kind of spin our wheels to come up with a solution that in the end is probably a very imperfect solution. And it's unfortunate from a clinician's perspective. In my lifetime, there's not that many drugs that I've seen come and go or come and stay. This might be one of these two where it actually might make a difference for a small group of patients that I have.
All right, thank you very much. Victor.
So as a previously practicing neurologist myself, when I took care of patients, now that I'm in industry, I feel like there needs to be more collaboration with external, not more, but maybe more focused collaboration, even with experts that can help us guide on what's important to the patient and the caregiver, especially in TD. I think that, I worked in the Huntington space as well, but the caregivers and the patients themselves are suffering quite a bit. And even though we show, for example, an AIM score that's significantly better than placebo, we don't know what that means. And at the end of the day, we get FDA approval, but we really need to focus more on what the impact on the patients and the caregivers.
All right, great. Thank you. Barbara.
Wow, so many things. I think the word collaboration that just came out of his mouth actually struck a chord with me, because I do hope that in the end, if you think of every party that's here, we still want the same end result for our patient, whoever the patient is, depending on the route. But unfortunately, there are so many hurdles that get put in our way to make that difficult. And to Jean's point, is it a lever that a health plan does to ensure that evidence-based medicine is practiced, or does it have to be a sledgehammer so that we restrict it to the point that we can survive with our budgetary restrictions for the year? I would much prefer have it be just a little guideline that we make sure you stick to evidence-based medicine, but we can't, because the costs are so high that it's not sustainable anymore. So the collaboration word, I think, is what I would like to take away. We all want the same end goal, and it might be a little Pollyanna of me, but it's just, we can't sustain this for much longer.
Thank you. Paul?
I guess I could say ditto. It is too complex. I'll keep my recommendation simple, and it's the last time I alluded to it earlier, is to have our deliberative professional societies get on this business much quicker than they do today, so that we have most of us are compelled or have organizational obligations to assess the standard of care. And we all like to use the American Academy of Neurology or the American Psychiatric Association as a measure of that standard of care. When we wait years for those guidelines to come forth, it simply creates another obstacle to an already challenging situation. And relatively speaking, that's fairly low down on the scale of things, of wish list, because I'd like to say, everybody lower the launch prices and we won't have so many problems.
Charles.
I actually agree with that, and I want to focus a little bit on quality and the concept and the ascertainment of quality. All of our lives, specifically mine, would be significantly easier if the professional association said, here's what good looks like, here's what great looks like. In the mental health space, this is significantly lacking. Mental health does not have a number that is a blood pressure or a radiologic measure or. These two organizations, AAN and APA, are extremely reticent to having to take that stand. But imagine how easy all of our jobs would be if they said, yeah, we base quality on the XYZ measure. My trial shows the achievement of the XYZ measure, your access and reimbursement is based on the XYZ measure. So we completely agree that collaboration, but working towards that end result of what does good or great look like, specifically in the mental health space, will advance this significantly.
Thank you very much.
I just wanted to...
yes, please.
I have very little to add to the wise words that have been expressed in the last 10 minutes, but the business about drug cost is a mega issue, and a couple of our presidential candidates in recent elections have talked about it, and then it's been forgotten about. I have a number of patients who get their drugs from Canada. Occasionally, some travel to Europe to purchase them. And it's the same drug available in this country for a very exorbitant cost. So this is true of some of the Parkinson's drugs, are very much cheaper even in Canada. And it's very easy to get them from that source. So I think and the same is true of DBS, by the way. Deep brain stimulation in India is about 1/4 of the price that it is here, for the same technology, for the same instrumentation, for the same skill of the surgeon that's doing it. So why is that? Why are we allowing this to happen? I don't know what Medicare insures a large enough section of the population. If the federal government wanted to do something about this, I guess they could. I don't know. I'm not a politician, but there must be a way. So I guess I'm broadening the problem beyond what we've talked about for the last 8 hours.
That's perfectly fine to do. I would like, we're going to go around for the CEPAC comments, but I would like to pause just for a second to thank our distinguished policy roundtable. I have one quick ask for the two manufacturers. Going forward, to make the job, even while we're working on better outcome measures, when you guys use the imperfect ones, use them imperfectly the same way. So measure outcomes at 6 weeks together or 12 weeks together. Use the same cobbled together aims plus measures, because lo and behold, doctors, patients, and others will be able to actually decide whether we can tell one drug from the other in a way that's more, I think, true to what we want out of the system. So I wanted to identify the fact that we want to be done by 4 o'clock, and I know some of the CEPAC members have already had to leave to catch trains, etc. But if you can all also try to capture it in one glorious sentence as a take-home point, an ask of the future, or action-oriented is always preferred, but sometimes recasting the question in even a different or broader light is just as helpful. So Julia, can I start with you?
Sure. Yes, I would just second the need for better outcomes, an outcome that truly reflects the patient impact of TD and moves beyond the AIM score, because I really struggled with whether or not these new drugs were effective based on the AIM scores. So I'd like that reflected in the report.
Thanks. Keith, you're last, at least for the near future CEPAC meeting.
I've had so many memorable comments over the years.
You don't get to tell us that we're asking the same questions that we asked 7 years ago.
No. No, I think, I've spoke at breakfast and again at lunch with some other members, and I think many of us were underwhelmed when we read the initial material. But happens so often, this really kind of that just served as the reason for us to gather here, and really has led to a much more spirited conversation about the bigger picture and a lot more necessities. And so it's happened many times before at this, and that's the part I will miss. But I look forward to reading many exciting reports in the future. Thank you.
Thank you, Keith. Ed?
I struggled coming into this, wondering why we were dealing with this topic, and I thought I knew how I was going to vote going in. But after all the compelling testimony, I have to admit that I changed at least half of my votes, and I have a greater appreciation for the population that suffers with this problem, the potential solutions to that, and everybody's difficulty finding an answer. I think I feel that way after all of these meetings, having done this now for about a year and a half. Thank you.
Thanks, Ed. Jean.
So I will echo the previous statements. My one request for the report is a plea to improve the use of patient-recorded outcomes measures overall in the field and for lower prices.
Thank you. Brian.
It's once you get around through 3 or 4 people, it's going to be even worse for the people after. We're all saying the same things, but qualities I just find difficult to deal with when we're talking about specific small patient effects. I mean, small in terms of looking at their bodies. They aren't dying of it, but have huge implications for their lives, and I'm not sure that qualities capture that as well as I would like. So it makes it difficult to assess these drugs when, as has been said so many times, a score of 4 may be nothing if it's 1 point in 4 different categories, or maybe life-changing if it's in one spot. So I think we need a much better way to quantify, not qualify, but quantify what's really happening. And boy, I just, time after time after time, I think ICER gets thrown under the bus because ICER's come out and said a drug is too expensive, but it's not ICER's fault. It's the pricing at the beginning. It's the launch price that's the issue. So please, let's work on that.
Thanks. Kim.
As Brian just said, I think my comments will sound somewhat redundant. Similar to Julia, I would really, because I think what will be confusing to an external person who maybe didn't get to sit through or read the complete report, if you just look at the voting, I'm not sure it's an accurate reflection of the discussion that's been happening today. So 2 primary questions at the beginning was that, is the evidence adequate enough to say that there's a net health benefit? And the majority of people here at this table would probably have to say that they had to vote up against significance of values, and that was based on the AIMS. And I don't think I've heard one person here today say that they were very confident in an AIMS score. So I like what Dr. Tarsi had said before about offering it to the right person. I think that's what at least from a payer's perspective, we're looking for. And I think, from the policy perspective, I think we do need to get on the Pollyanna bandwagon and all come together, because short of that, nobody here was able to distinguish the benefit between either drug. So we are going to have some sort of competition, and if people aren't willing to come to the table, it is going to limit access to some degree.
Claudio. So I guess I echo Julie and Kim's point here about how it was a little bit frustrating when we knew logically how important some of these interventions could be for the burden on family caregivers, especially when they were helping to administer medications and drug adherence issues. And yet to be left with just kind of a theory of the case without some quantifiable metrics around the benefits on families and the family caregiving aspect, I think is a shortcoming. And I hope that if we put pressure on and a need to measure it, that when we measure it, we tend to value it, and then that will give more recognition and kind of drive a conversation around that area. And other than that, I would like to say that ICER did another fantastic job of getting us a good cross-section of presenters and experts. I think all the discussion here was very rich and informative, and thank you for that.
Thanks very much. Greg.
Well, I would second that. Thanks so much to ICER and to everyone who's participated in this very interesting session. I think the clinical trial data that we were presented with has very significant limitations, and we've discussed those, and I think that we should be expecting more from the manufacturers going forward in designing these clinical trials. With that said, I think that these two new drugs do have something to offer patients, but I would need to look at this from the standpoint of society as a whole, and I would like to see a set of guidelines developed that would be stepwise in terms of how these interventions are applied, that we should expect reduction in dose or discontinuation of antipsychotics, or changing to alternative antipsychotics before we get into adding a drug to deal with the side effect of another drug. I also think that the idea of negotiation of prices, or maybe some sort of reference pricing system, should also be invoked. I just don't think that we can expect society to pay these very high prices.
Thanks to ICER staff, modelers, experts. It was a terrific experience today. It strikes me that we've sort of had this presumption that TD is just something we have to live with because it's an acceptable trade-off with the burden of psychosis. But yet, as we use these atypical antipsychotics in different contexts increasingly, whether it be major depression in kids, PTSD, et cetera, I wonder if there's adequate informed consent about the risks of TD, particularly thinking about there are other alternatives in those conditions, which may not be the case in schizophrenia. So just something I've been thinking about. But thanks to all. Didn't mean to introduce another topic, but I appreciate the day today. Thank you very much.
I'm going to try to limit my comments on things that haven't already been said, but there's a couple things that need to be said multiple times, which is just like, thank you so much to the ICER staff for putting together an astonishingly good session with these wonderful expert panelists. The other thing I wanted to say is that I've been very influenced today and in the past by these questions of distributional justice that you had mentioned. So especially in the setting of psychiatric disease, especially in the setting of schizophrenia, where these people have delusions, are not able to advocate for themselves either individually or as a community, I think it's exceptionally important that we weigh that in our deliberations. I sometimes think about it in my own clinical practice is that I have a fiduciary duty to all patients, but the patient who's walking into my office with their wife and their daughter can advocate for themselves a lot better than a patient in the ICU who's intubated with a balloon pump. And I don't take care of psychiatric diseases, but this is the most extreme case where a patient population cannot advocate. There's walks for heart disease, there's walks for breast cancer. They're not walks for schizophrenia. So I at least as far as I know. So I think that it's critically important that in our deliberations we take this into consideration. In my case, it wasn't influential to change my vote because the incremental cost effectiveness ratios were so far off normal thresholds. But had it been closer to the normal thresholds, that would have been very influential in my vote. So I think it's something that, to keep in mind. Thank you all so much again.
Thanks. And I think the thing I'm left with is how difficult a task it is for us to talk about cost effectiveness without real-world cost data. And it's especially true in this context when we look at individuals with serious mental illness as among the most expensive and challenging patients to treat in the system. And then when you add to it a condition like this that just potentially exacerbates the stigma associated with their lives, we were asked, and ICER was asked, to model this on the basis of trial data that has none of that information. They did a great job, and I think the sensitivity analysis convinced us that these drugs are just too expensive. But we really need to look at the impact on hospitalization. State of Connecticut, second leading reason for hospitalization is the bucket of DRGs associated with psychosis. So it's obviously a major cost, and yet we were not able to consider that, yet weighed in on cost. So that is my final word.
Thank you very much, Chair. So just a couple of reflections, but I want to start with a very sincere thank you from the entire ICER team to the patients and the clinical experts who helped open the window on tardive dyskinesia for us. There was just a huge amount for us to try to learn, and you really did help us see the bigger picture in ways that we could not have otherwise. Similarly, the manufacturers were incredibly helpful all the way through and working in very good faith throughout the process to help critique our modeling, to help share the frustration and the hunched shoulders around some of the outcomes and the uncertainties. So we appreciated that collaborative spirit to that extent. But I am left, I guess feeling a little bit perplexed because it does feel like we are so far apart from the cost effectiveness and the pricing here, and what's going to happen in the community is not going to be what we all would want. It's just not. And it's very frustrating because of for all the reasons, but because of the patient population involved, as Oliver and others have pointed out. Because right now, Gene, your regulatory hammer, when that doesn't exist, it gets moved into the marketplace, and the only hammer that the payers have is to squeeze utilization down by creating, tighter barriers to care. And they can do it on an evidence-based process, or they can be completely kind of crazy. But it ends up creating that kind of barrier in all the different ways and stresses in the system. And that's supposed to be the feedback loop to actually drive politicians or others to make change. We do hear of increasing use of the work of the CEPACs in our report when payers sit down with the companies to talk about the price. And even when their negotiating leverage is somewhat limited and they feel like they really need to keep all the drugs on the formulary and keep access, et cetera, it's helping set the stage for at least some external benchmark to which to discuss what value looks like and how pricing can align with that. But we're still far from a world in which that's the default, and when the drugs come through, it gets thought of that way, and we end up having the fun of having meetings where we talk about how to get these drugs into the hands of every patient who can benefit from them, because they represent value at launch. And we've had that experience a couple of times, and it's very exciting to have those meetings. We have other meetings where we talk about things like integrating behavioral health care into primary care, bigger tectonic shifts in the way we deliver care that also offer the opportunity for great benefits to patients and savings. But so as frustrating as it is, because there will be a lot of tension and friction that will trickle down to patients in the system, I think we're still in a better place than we were 5-7 years ago. And the politicians are talking about it, if not always acting about it. But we may be headed towards a regulatory hammer that includes things that, will sometimes work and sometimes not work. But I think the system's going to change over the next 5 years from now when we're here. I actually highly doubt that we'll be having the same discussion around the same players doing the same things. So with that, again, my last thanks goes to the CEPAC. The degree to which you guys take a deep dive into the data, thinking critically, the questions you asked, as the data were presented earlier, the summary of the evidence, I think was exactly what we would hope to have as a public process. It's an honest prodding and probing and tearing apart and wrestling with the way that the evidence exists and how it relates to practice in the real world. So thanks to the CEPAC, my own thanks to the ICER research and program staff, and again, to our policy roundtable. So thank you. Our final report on this, wrapping all this material in, will be out in the next 2 to 3 weeks at most. You'll see notice when it goes out. And with that, I just want to thank you all and hope you have a safe travel home. Thank you.